Chair, broadcast is ready, and you may call the meeting to order.
Thank you very much. Let me adjust my volume so that I can hear. There we go. Good morning, everyone. Welcome to the Legislative Commission's Subcommittee, Budget Subcommittee. We'll go ahead and move forward this morning. Welcome to everyone. And I believe, Ms. Kaufman, you will be calling the roll.
That is correct, Madam Chair.
Please,
Senator Brooks. Senator Brooks. Senator Cannizzaro.
Here.
Senator Dennis.
Here.
Senator Don Daraloop. Senator Severs-Ganser.
Here.
Senator Goycochea.
Here.
Senator Hammond.
Here.
Senator Kiekeffer.
Here.
Senator Ratty.
Here.
Assemblywoman Benitez Thompson.
Here.
Assemblyman Frierson.
Here.
Assemblywoman Gorlow.
Here.
Assemblyman Hafen.
Here.
Assemblywoman Howdege.
Here.
Assemblyman Levitt.
Here.
Assemblywoman Miller. Assemblywoman Miller. Assemblywoman Monroe Moreno.
Here.
Assemblywoman Peters.
Here.
Assemblyman Roberts.
Here.
Assemblywoman Titus.
Here.
Assemblywoman Tolles.
Here.
Assemblyman Watts.
Here.
Chair Carlton.
And I am here. So, Ms. Kaufman, if you would please, Assemblywoman Miller will be joining us a little bit later, and Senator Don Daraloop is having connections problems, so we will mark them present when they do tune in with us.
I am here, Chair, using my phone hotspot, so we'll keep our fingers crossed. Cox Cable right at 8:30 said, sorry, we're working in your neighborhood. So
Okay.
see how this rolls. Thank you.
All righty. Well, we'll keep up with you. If anything happens, just reach out to us and let us know. So with that, committee, we will go to our first public comment period. Being no physical location for this meeting, public testimony under this agenda item will be presented by phone and or written comment. That contact information was posted on the agenda. We will take up to approximately 30 minutes of public comment at 2 minutes per person at the beginning of the meeting, and all other public comment can be submitted written or at the end of the meeting. So with that, broadcast services, do we have anyone in the queue for public comment this morning?
Good morning, Madam Chair. Thank you. Yes, we do have one caller. Would the caller with the last three digits 048 please slowly state and spell your name for the record? You will have 2 minutes and may begin. Well, unfortunately, it looks like that caller hung up just as he was ready. I apologize. And there are no more callers at this time.
Thank you very much, broadcast services. I appreciate that. So committee members, today we have Health and Human Services, one of our larger budgets. This budget is overseen by the Subcommittee on Health and Human Services during the actual legislative session. This is a chance for all members of both committees to get a high-level overview, and for those members that are not on that subcommittee to have a frame of reference and have an opportunity to hear about the issues and ask questions on this particular item. But those members that are on this particular subcommittee will be hearing a much more in-depth presentations on each individual item as we move through the session towards resolving budget issues. So with that, I would like to welcome Mr. Whitley, the director, to start us off today. Good morning, Mr. Whitley.
Good morning, Madam Chair and members of the committee. My name is Richard Whitley, and I serve as the director for the Department of Health and Human Services. And with me today is Beth Handler, who serves as the deputy over programs, and Stacy Johnson, who serves as the deputy over finance. And I was trying to, in accordance with the LCB letter, on what they wanted to hear. I thought it was hard to just launch into the budget without acknowledging, that my department has really developed and revised, and even today present the budgets while concurrently responding to the public health crisis that's been going on over the past 10 months. So some divisions serve primary roles, but all serve to protect the public. And so I think it's important for me to acknowledge that for my staff today, that we present these budgets, which are regular in the season of the work that we do as public servants, but it's occurring in a time that we've not ever experienced before. So with that, if I may, I'll proceed with my budget presentation. Starting on slides 2 and 3, this summarizes the department's mission and statutory authority, as well as our organizational chart. The department is organized into 5 divisions framed around populations served, such as aging and disability services, child and family services, public and behavioral health, and then functions, welfare and supportive services, and Nevada Medicaid. Turning to page 4, these are our practical and really come from responding to the pandemic in terms of our department priorities. The first one is leveraging and maximizing resources. One of the things that we really have learned in the past 10 months is that the focus on consumers, that every service that we have in our department has a process for how to become eligible or receive them. And the consumer experience is not always helpful as perceived by the consumer. And so one of the initiatives that you'll see without a cost, but with some realignment of programs, is a focus on consumer services under this priority of the governor to leverage and maximize resources. So you'll see a few transfers from my budget, and then within aging and disability services, you'll hear more about what we believe and what we've demonstrated to have gained from really organizing these services in a response to consumers. The goal is to really, in the end, just to improve the consumer experience. The other priority for our department is standardization. And again, something demonstrated in the pandemic, but really I think that we've been working towards it incrementally, is just the value of data, not just collecting it or having databases, but and not just issuing reports that are categorical, but actually framing information that identifies areas where we should have a concern or where there's an intervention point. And you'll see that in our as one of our across the division priorities in terms of some changes. Again, not a cost, but I think an alignment of data analytics that will really help our state. I'm so proud of our state biostatistician. If you haven't looked at our data dashboard, she really, Kyra Morgan, really has with her team stood up an information system that tells the story of how we're doing and where we need to intervene, and where testing needs to occur, how communities are doing. She's translated this for immunization, and this is really just too good not to apply across the division. And those of you that have been around for a while, you do know that a lot of our programs are federally funded, and so in state agencies, we really have haves and have-nots when it comes to data. Some grants come with surveillance and a data system, others do not. And so this is a way of really getting at how to best capture information about really our most vulnerable populations, as demonstrated by what we've been able to do during the pandemic. Turning to page 5, the budgeted funding sources by department. Federal funds requested is 56% of the total in the governor's recommended budget. General fund requested is 22% in the total governor's recommended budget. And other, such as tobacco settlement and fees, make up 22% of our overall budget. The most significant change is found in federal and other, and it's due primarily to the federal medical assistance percentage changes that have occurred, and changes in recording drug rebates at Medicaid. Turning to page 6, this slide focuses by division. General fund request for the upcoming biennium is $3.3 billion, which represents a growth of $286 million or 9.6% from the previous biennium. The largest growth is in Medicaid with $265 million, followed by Aging and Disability Services with $22 million. And the primary reason for this increase is caseload and inflation. Turning to page 7, this shows the total positions for the department. There were 6,154 positions that were approved in fiscal year 21. This increase to 6,442 positions in fiscal year 23, which is an additional 288 positions. And this is, again, primarily due to caseload growth. Moving now into my office's specific budget, turning to page 9. My office oversees the divisions within the department and concurrently administers some specific programs, grants management, Office of Consumer Health Assistance, Developmental Disability Council, family planning, the Upper Payment Limit Program, and the Indigent Hospital Care Program. Turning to page 10, this shows the budgeted funding sources. Total revenue is $187 million for the biennium, of which general fund is 5% of revenues, or $10.5 million for the biennium. I would note that 40% of the general fund is recouped through a cost allocation plan. Federal funds are 25% of revenues, or $46 million over the biennium. The majority of revenues, 70%, is other fund. And that's made up of tobacco revenue, ad valorem, property tax from counties, and unmet free care obligation. Turning to page 11 are the specific budget accounts. And then if you turn to page 12, we highlight the major enhancements for the Director's Office budget account. The first one I mentioned earlier, centralizing data analytics. The intent is to move the analytic culture that's really just centered on reporting or reactionary, as I mentioned, categorically, to a culture that's more proactive and really drives policy and decision-making across the department. That as I said previously, some of the programs have more funding because of the federal program, and it would be a way of equalizing, I think, the tools that are available. It's also a very hard to recruit for skill set, and the investment in staff. I would just highlight that Kyra Morgan, our state biostatistician, started at a program level in our cancer registry and really has stayed with the department out of dedication to the work, and has really led this effort. And in talking with her, she really does value the investment in staff who display an interest in data analytics, and believe that by offering training across the department, we really can invest in those staff with no additional cost. It also helps to centralize the supervision, and then hiring could be consistent across the department. The second is the transfer of consumer health assistance and 211 program from the director's office to aging and disability services. These programs work closely with the long-term care ombudsman, adult protective services, and really the goal here is to create a consumer health and advocacy and protection unit. Again, during the pandemic, we have found that consumers need assistance with navigation. If we identify difficulties, making adjustments to 211 and to other resource centers so that they can better assist people prevents the problems for consumers. We also have some consumer direct assistance with navigating the cost of healthcare, whether someone is uninsured or underinsured, the billing. Last session, we implemented in this unit the surprised billing legislation to help consumers. And as most people know, people who have a need don't usually have a single need. And so I think that in combining these program functions around consumer protection, we really can better assist them, again, with no cost, but with structure. And the third one is the Board of Trustees for the Fund for Healthcare to Indigent Persons. They voted to redirect the ad valorem tax revenue from hospital supplemental payments to counties to offset their long-term care assessments. And NRS 428 requires the Board of Trustees to administer the fund. This will reduce the hospital supplemental payment as follows. Fiscal year 22, 101 million to 72 million, which is a $29 million decrease approximately. Fiscal year 23, 114 million to 82 million, which represents a $32 million decrease approximately. The county match program also draws federal match, so we don't lose any federal match. It just shifts from one program to another. Turning to page 13, this reflects the budget reductions from, and you can see here that this reduces the family planning program from 3 million per fiscal year to approximately 2.4 million a fiscal year. And that is the actual amount spent in the base year, which was $2.319 million. So although it's a reduction, it is based on what the actual expenditures were. Turning to page 14 shows a breakdown of the Healthy Nevada funds. The Healthy Nevada funds come from the Tobacco Master Settlement Agreement, and these revenues have remained steady over the past 10 years at approximately $24 million a year. We are obligating approximately $3 million less this biennium due to the budget sweep of $16.8 million during the special session. The balance forward at the end of the biennium is projected to be $17 million. On average, approximately 92% of the legislatively approved budget is actually spent. So if this continues, the balance forward at the end of the biennium will be approximately 20 million. Cash flow analysis shows that we will be good this biennium, but depending on year-end reversions, redirections may need to be made in the future. The next slide shows how the Grants Management Advisory Committee allocates the funds. The chart shows the categories where tobacco funds are proposed to be spent and the difference from last session. The main areas of change are senior RX and independent living. This reduced funding reflects changes to Medicare Part D program, which eliminated the need for a pharmacy subsidy program. Funds requested to move to independent living to address broader services for the same population. Southern Nevada and Northern Nevada mobile outreach safety teams. This increase is due to replacing the general fund with Healthy Nevada funds, which changed during the special session. And then autism, replacing Healthy Nevada funds with TANF funding. Turning to page 16 shows the Title 20 Social Services Block Grant. The Social Services Block Grant is an allocation of funds through the Federal Social Security Act. And these monies help support social services for vulnerable populations, children, adults, families, through 5 broad goals: economic and self-support, self-sufficiency, preventing and remedying neglect or abuse of children or adults, preventing or reducing inappropriate institutional care, and securing referral or admission for institutional care when other forms of care are not appropriate. We are projecting a slight increase in the total funding available, and the amount allocated for administrative costs was revised to more accurately reflect the operating expenditures, freeing up additional funds for services. Turning to page 17, the next 2 slides cover the pass-through funds to the Division of Healthcare Finance and Policy. These are for supplemental payments to hospitals. Because the rates paid by Medicaid are below the upper payment limit, which is the Medicare rate, the supplemental payments help offset the reimbursements made by Medicaid. The first program is the upper payment limit holding account. This is a pass-through account associated with private hospital upper payment limits. The slide shows the total amount of the contracts and the amounts that will be reverted. We are projecting 46 contracts, which is approximately $12 million each year. The budget includes transfers to Medicaid of approximately $9 million and a reversion of approximately $3 million. With federal match, this allows Medicaid to make approximately $18 million in supplemental payments each year. Turning to page 18, the second program is the Indigent Hospital Care Act. This program was established to reimburse hospitals for care that is provided to the uninsured. The fund is administered by the Board of Trustees that is appointed by the governor. The Board of Trustees consists of 4 county commissioners, a social service agency director. The counties seek reimbursement for indigent expenses in excess of $25,000. The board may also transfer funds to the Division of Healthcare Finance and Policy for supplemental payments to hospitals. This chart shows the 2 funding sources received in this budget: the ad valorem tax, which is estimated at approximately 17 to 18 million each year, and the unmet free care obligation, which is estimated at approximately 26 to 27 million each year. The unmet free care obligation has grown as the uninsured rate has fallen. Use of these funds are determined by the Board of Trustees, and there are 4 allowable uses. 1 small amount to NACO to oversee the account and administer the claims. 2 traditional accident fund payments. 3 offset county match. And 4, finally, the majority of the funding is transferred to Medicaid to be used for supplemental payments. This is expected to be $23 million in fiscal year 22 and 26 million in fiscal year 23. And this will allow Medicaid to pay approximately 72 million in supplemental payments in fiscal year 22 and 82 million in fiscal year 23 with the federal match. That concludes the budget accounts that are actually contained within my office. And so I'd be happy to answer any questions.
Thank you very much, Director. That was very good. It's a very good breakdown of everything, and will allow us to ask some questions. I think with one of your major initiatives, the data initiative, I'd like to understand a little bit more about what you're actually looking at and where you're trying to go with it, so that I get a better feel for what you're trying to accomplish.
Sure. Again, for the record, Richard Whitley. It really is moving the state biostatistician and the programs that the data components. You know, in public health programs, there's usually a surveillance arm that doesn't always get funded, or at a federal level may roll out over time. That's really the data collection piece. And then some programs invest a lot. Actually, we have some that are just data analytics. And then we have other programs, or we have non-programs, but we know we have a problem. And so it really is to move the positions that are currently doing the work of data analytics under the state biostatistician to my office. One of the challenges that I found during the pandemic has been, in all honesty, the control of data without doing anything with it. And so having it in this office under my authority and as the director of the department frees up the access for the state biostatistician to be able to do the analytics on populations. I think if you even look at our DHH website, one of the things that Kyra stood up is a data dashboard by legislative districts to show what the health status of the people legislators represent. I think that level of data analytics can only be achieved when we bring the categorical programs together to tell what's happening on a community level. Otherwise, programs that we have that actually may be body part based only collect that. So women's health is a good example where there's we have a categorical breast and cervical cancer. Certainly women are more than those body parts. So so telling the whole story when we initiate outreach of who the population is and what their needs are, there's value to be gained from that, I think, not only for the state, but also for our community nonprofits in terms of working towards the same goals. And again, I think what illustrates this best is the COVID dashboards that are up. I welcome input on the dashboard that Kyra stood up for legislative districts on health indicators. But it really is to bring together under singular leadership the data analytics. Otherwise, these are just categorical program functions embedded in a program that don't really get at what the consumer needs are. And more than ever, people have needs. They don't, I listen in when my assistant talks to consumers calling in, and, they may start with an initial issue, but they always have multiple needs that occur at the same time, whether it's food or housing or underlying health conditions. And so being able to better capture that story at a population level and then at a community level, I think will better serve our programs. So in the budget, you can see what those specific positions are that we're proposing to move under my office.
Okay, thank you very much. So I think I do have some questions from some members. Dr. Titus, did you have a question?
Yes, thank you, Madam Chair. And Director Whitley, always good to see you and hear what all you are doing, and all your hard work is much appreciated for the state of Nevada. So thank you for that. I have a question regarding the presentation that you did earlier on in the slides on the Medicaid and restoring the 6% decrease, and the fact that you have a $285 million increase in the general fund appropriations, and your reason for that is that due to the increased caseloads, Medicaid caseloads is one of your reasons. And I'm just curious about, and obviously we don't need that today. I know this is a high level view. So during the hearings, when we break this down, information regarding your negotiations with your Medicaid providers and how that works. And then the answer that the question that we keep asking that we don't have any answers to is, what was the difference? And we were told, in actually the increased number of Medicaid folks or recipients who actually accessed care, because there was a disconnect between those folks who signed up and those folks who actually accessed the care. So we see these high numbers of recipients, but not necessarily increase in cost because they didn't go to their providers. I know that there is a cost every time somebody signs up, especially in the managed care world, because they get paid per recipient. So I recognize that's a real cost. Once you have somebody sign up, there's a cost to the state. But then, when you renegotiate some of those reimbursements to those providers, or to the managed care organizations, I'd really like to see a lot more details on that. I know that's not for today, and I'm sure other members want that too, and I'm sure the chair will ask for that. But that's where I'm going with this, and just some of that. And then I also heard about the Medicaid budget, maybe that there was a large carryover from what Medicaid had in the budget in the bank, and it carried over. And I'm wondering whether there was a delay in paying Medicaid providers if you ever actually took that 6% out of reimbursement and now you're putting that back in. Was that ever initiated? And that's a question maybe you could answer today.
Okay. For the record, Richard Whitley. First, you'll hear more detail on the Medicaid budget when Division of Healthcare Finance and Policy presents, and I think including the first issue you highlighted, which is that during the past 10 months, when primary care, for example, maybe hasn't been seeing patients, or there were limitations, what that actual cost was and how do we recover those what was paid out to managed care when in fact perhaps no or fewer services were delivered. So you will hear about that in detail, and we are monitoring all of those, and you're exactly correct in the reduction to access. One of the reasons on your last point about funding that was carried forward is that after the special session, the Secretary of Health and Human Services declared the extension of the public health crisis, which enhanced our FMAP, and that's done in 3-month increments. We also don't account for it in this budget because it occurred after the budget was submitted. That this before the Trump administration ended, the Secretary of Health extended that through June. It's really difficult to budget on that because it's in 3-month increments, but we won't know till we're well into our budgets if the current administration will extend that yet again. That will have huge savings. I don't want to misspeak, but I believe it's around $30 million of general fund saving with that enhanced FMAP, again in 3-month increments. So that does account for some of it. You'll hear in more detail from the Division of Healthcare Finance and Policy, even in their overview today on those topics that you were asking about.
Great, thank you. Thank you. I listed on where you mentioned the increasing of funds, so that's where I came up with that question. So I appreciate that, and we'll look forward to hearing some more details. Thank you, Madam Chair.
You're welcome, Doctor. I usually go to you first on some of these because I know you're queued up and ready to go. So that's how we do it. Team sport. So other members of the committee have questions at this time?
Madam Chair, if I may.
Speaker, please, yes.
Just a couple of questions, one of which is not, I don't know if I'm jumping ahead, but Director, in the presentation, I believe it was on page 15 or 16, and forgive me if I was going through this and you addressed it, but it appears that there's about $5.7 million that's being proposed to be cut for autism services. And I just wanted to just get a little bit of a dive in what's going on there. I hope that that is really a substitute for some federal aid and that we're not just cutting those services, but that jumped out at me. So if you could address that, and then I have one other area of questions.
For the record, Richard Whitley, I mean, what we represent in our budget, you'll hear about the autism program in aging and disability, but in my budget, you see a change from the Fund for Healthy Nevada, the tobacco settlement dollars, replacing that funding with TANF, temporary assistance for needy families.
Okay, so I jumped ahead.
So there isn't a cut in this budget. There's a change in funding source.
I'm sorry. We kind of talked over you. You said there is a big cut or there's not a big cut?
No, it's a change in the funding source.
But not a cut to the actual
Not a
delivery
cut.
service?
No, not, I mean, I don't, you'll hear in aging and disability, the multiple funding streams make up autism services. And the action that I'm taking in my budget is a change in the funding source from Fund for Healthy Nevada to TANF, temporary assistance for needy families.
Thank you, Director. And my other question is, I don't think directly addressed, at least in this part of the presentation. So if it's going to be coming up in a later part of today's meeting, feel free to let me know and I can ask at that point. Director, you were very responsive, as you always have been. Several months ago, when I reached out about NMAP and some proposed changes that would have, I think, an impact on the program for providers that under the 340B providers. And there were concerns already about a proposed new model. But I think there's also concern about it being exacerbated by budget challenges. So I thought that the plan some months ago was to kind of abandon in the midst of all of this proposed model change. But I think many of us got some communication recently that it was implemented as a change and took effect, I think, actually a few days ago. Could you address that and the impact that this budget crisis might have on the delivery on the providers in 340B?
Sure. For the record, Richard Whitley. Again, you'll hear more detail about that in the Division of Public and Behavioral Health, where the HIV medication assistance program is managed. But the concerns from stakeholders and from the federally qualified health centers or service providers, nonprofits that provide the service, were really twofold. The first, as I understand it, was this change that occurred that looked good on paper in terms of a cost savings, which was to make a shift from where the implementation of pharmacy services occurred. The program did an RFP, they selected Walgreens, and really the initial outcry from providers and consumers was that it shifted medication and the use of the pharmacist as a discipline of the treatment team outside of the clinic setting, and that would be disruptive. And so that was stopped. That is not going forward with Walgreens. The program stays intact with medications being administered at the clinic level. I think where the issue of the funding comes from the state and then the driver and the discussion that continues is rebates. Should the state be the single purchaser and collect the rebates and then distribute the money out? Or should we fund the clinic to purchase the medication, leverage it with their resources, and be able to take advantage of the federal opportunities for rebates. No change has occurred. What they're really doing is holding to the tension of the discussion. I think there are ways to get it to share the same goal. I think if we can the goal should be to maximize the rebates, because we should never want a waiting list for people who are living with HIV to get their medications. But if the program can be implemented at the local level and they can leverage the resources to meet the needs, I think we could achieve it that way. That's where the discussions are being held. So no change has been made. A letter was issued from Administrator Lisa Sherrick indicating that, and that they would have follow-up meetings for discussion. It is a polarizing topic because it's where funding, should we collect it at the state and redistribute it, or should we allow locally to collect it? And again, I think we can share the same goals in this and serve people. Services are best delivered locally. So I think there is something to be said in those resources being anchored to the clinics providing them. You'll hear more about that. I probably went on more than Lisa Sherrick will cover this in the Division of Public and Behavioral Health presentation.
Great, thank you, Director. And I'll look forward to kind of an expanded conversation about it. I really want to be sensitive to, this part of it is policy, not budget, but I want to be sensitive to folks that are in a community that is not as comfortable with change, and they have somebody that they trust currently. And I would not want to implement something in the name of potentially saving money, but also losing people's willingness and comfort level with their provider and being able to get their medication. So I will hold off. Thank you, Madam Chair. And when we revisit it within the divisions, I may have some follow-ups.
I got muted. Thank you, Speaker. And I know that was an issue with some other members. They brought it up. Now the person who's going to be presenting on that issue's got a heads up, and they will be prepared for you. So that's a good thing. Senator Gansert, you had a question?
I do. Thank you, Madam Chair. First, what's the best way to let you know that we have a question? So I had chatted to you and I couldn't tell if you could see it or not. And then I did the hand. So would you like each member as a committee raising hands when we have questions, or how should we let you know?
I did see it and responded okay. And it was just a matter of, if I don't get to you right away, it's because I've had other members reach out, and I keep a list and I just go right down the queue. So,
no,
and if I skip you, don't ever, at the very end, don't ever hesitate to just say, Madam Chair, and hop in there. Okay.
Thank you. But do you like us to chat to you, or would you rather have a hand up?
That's fine. That's fine. Individual members like to do it different ways. That is perfectly fine. Yeah.
Thank you. So most of my questions were covered. So I appreciate the clarification on autism, and then the question from Dr. Titus on managed care, because we are paying for Medicaid per patient per month and the utilization is down. But I want to take a moment to thank Richard and his staff for all the work that they've done since my hand was already up, because I know it's been a very trying and challenging time, and we truly appreciate all the work that you're doing. So I'll hold all the rest of my questions. Thanks.
Okay, thank you, Senator. Are there other questions from other committee members at this time? I do have just a couple brief ones. I'd like to, Mr. Whitley, ask you about 211. I remember when we instituted 211, and it was basically to be just an information source, so that if folks didn't know where to go for assistance, they could call there, easy number, get a referral, and they would help guide them whatever direction it would need to be, whether it was a problem with a medical bill, assistance with their electric bill, whatever issue had come up. So what I see you're trying to do here, will all those same functions still be part of 211? And what expansion, I think I heard you say you were going to expand it a bit, but I didn't quite understand where you were going with that.
Sure. For the record, Richard Whitley. I think the expansion comes from being better informed about what consumer needs are. The fragmentation of like the ombudsman, the services to the elderly and to people with disabilities are, as you know, scattered across our divisions. But the information opportunity, I think the expansion comes from being better tied to what we're seeing consumer questions are, and being able to sort of pivot to that a little bit more quickly. We've seen what 211 really has become is a navigator for clients. You know, most healthcare is very complicated, social services, DEETR, but you know, the underlying issue, if the underlying issue is poverty or underemployment, the service array are vast. So nothing being taken away from 211 as a resource, but really just tying it closer to the consumer programs that could help people so they don't have to sort of get in multiple lines and can actually be connected. So no change or decrease in the service. I just see that it more timely information for 211 and to be relevant to what the consumer needs are in a pace that's in touch with what's going on. And the reason I think that aging and disability hubs nicely with the consumer piece is, you know, they broaden the ombudsman piece. So if there is a need for follow-up to investigate or to ensure safety, they broaden that to all populations. And so 211 certainly serves all populations. So it just really is when we look at it, and I think we have a paper on it that I'd be happy to share. I wasn't sure if I should offer everything up in this hearing or wait until our subcommittees, but we do have a paper that actually shows the various components and what the gains are.
And thank you, Mr. Whitley. And 211 has been invaluable the last 6 to 7 months for folks to be able to reach out and get assistance. And at times when I don't know where to refer them to, I'll call 211 and see what the different options are for folks. So I'm hearing you say there's not going to be a significant change to the program. It's just going to be where the program is housed.
For the record, Richard Whitley, correct. No decline in the service or change in it. No change in funding or support. So you are correct. And I would just add that family resource centers during these past 10 months have also been a resource that people have utilized to navigate.
Okay, thank you very much. I appreciate that. Committee members, any other questions of the director on the items that he's presented to us today? Not seeing anyone else wishing to be recognized, then I believe we can go ahead and move on to the next item, which is healthcare financing and policy. And I believe we have the administrator, Ms. Bierman, available for that.
Yes,
Good
good
morning.
morning. Thanks. Just want to check, we do have a PowerPoint. I might need just a second to get that up.
That's good. We're fine.
Oh, great. Thanks. Well, good morning. For the record, I'm Suzanne Bierman, Administrator for the Division of Healthcare Financing and Policy. Thank you for the opportunity today to present information on the budget for the Division of Healthcare Financing and Policy, of course, also known as Nevada Medicaid. Joining me today are the division's 3 deputy administrators, Dwayne Young, who oversees policy and programs, Cody Finney, who's the deputy administrator for managed care and compliance, Philip Burrell, our deputy administrator for finance, for Finance, and Melissa Lawfer-Lewis, who is the division's Administrative Officer for Finance. So next slide, please. Oh, sorry, here we are, thanks. So here we have information on our vision and mission, and I did just want to take a minute to talk about the program at a really high level and kind of explain how that wraps into our vision and mission. So we, of course, do administer both the Medicaid and the Checkup program, which is the Children's Health Insurance Program. As I know you've heard earlier in the state of the state, Medicaid is now covering approximately 1 in 4 Nevadans. These programs function as the state's health insurance provider for low-income Nevadans. Medicaid makes it possible for Nevadans to get and stay healthy. Things like having health insurance allows individuals to access needed medical services, visits to the doctor, coverage for hospital stays, payment for prescription drugs, to enable Nevadans to remain healthy. It also provides financial protection, allowing access to those needed services without fear of expensive medical bills and without having to make really impossible decisions between paying for food and groceries or rent and mortgage. So just wanted to provide a little bit of information about the program, how it works, and along those lines, it is jointly administered by the state and the federal government. There is a piece of our vision and mission here that references maximizing potential federal revenue. So did just want to provide a minute explaining that dual nature of the program. We work closely with our federal partners, the Centers for Medicare and Medicaid Services, or CMS. They do fund the majority of the program, which we'll discuss later in the presentation. I know Director Whitley already mentioned some of the federal medical assistance percentages, so no, that's always of great interest, but to just want to highlight that dual nature and that the Medicaid program generally is the largest source of federal funding that states receive. Next slide, please. Okay, here we've outlined some of our priorities. We did engage in strategic planning efforts to identify the priorities listed here, ensuring health coverage for all Nevadans, recognizing the critical role of primary and preventative care services and the important role of behavioral health. Really wanted to focus some efforts and energy on promoting strong starts for children and families. We know that the early years are so critical to overall health outcomes, and also aware of demographic shifts on the other end of the age spectrum, and really want to promote healthy aging for Nevadans. Finally, we do recognize that Medicaid is a significant piece of every state's budget, including Nevada's, and want to be cognizant of that and look for initiatives to promote sustainable rates of growth, and have noted here some strategies for prescription drugs coverage and pricing that we've been working on. Next slide, please. Okay, here is the division's organizational chart. I'll highlight some of the functions of the division here. As we heard earlier, we do oversee large contracts with managed care organizations to provide services to the majority of our population. I believe it's up to 74% of Medicaid recipients who are now covered by managed care. Certainly, that's the primary delivery system model that we use in Washoe and Clark County. Some exceptions for age, blind, and disabled populations that are not included in managed care, and the rural and frontier areas. But the vast majority of Nevadans in Medicaid are served by managed care, and certainly you can see on our org chart that overseeing those contracts is a key part of what we do. We also still do operate a fee-for-service program, which requires us in many ways to kind of act as a commercial health insurer would. And so you can see here some of those activities outlined as well, things like enrolling providers, processing and paying claims, providing oversight of provider billing and utilization review activities. So here you can see how we organize the work among the division, and we do currently have over 300 employees and our 3 deputy administrators who are outlined here, who all play a critical role in guiding and monitoring the division's work. Next slide, please. Okay, this slide outlines some of our summary of operations. I think that I hit on a lot of this in the prior slide, so I won't belabor a lot of this here, but again, it's a joint program administered with the federal government, and do have those 2 service models that I just mentioned, fee-for-service and managed care, in order to together to serve the state's low income and vulnerable populations by providing health insurance coverage. Next slide, please. Okay, this is a slide that we use pretty often, and it contains some fast facts about the Nevada Medicaid program, really highlighting and showing the broad impact that the program has. The first one, again, we've already mentioned it, 1 in 4 Nevadans covered by Medicaid. When I did this presentation about 2 years ago, that number was 1 in 5, but certainly have seen, as has already been mentioned, significant increase in our program participation since COVID and the accompanying economic crisis. Also, certainly a large share of the state's budget. I think historically it's one of the top 2 general fund expenditures for the state, and I think that is also true around the nation, Medicaid, education, and corrections for most states. We do highlight here that Nevada Medicaid does pay for the majority of the births in the state, and also just wanted to highlight the important role that we play in funding long-term care and nursing facility care. Those services typically aren't covered by commercial health insurance and Medicare, so Medicaid does cover and pay for the large 62% of nursing facility bed days. Next slide, please. Okay, here we've highlighted just a couple of our accomplishments. As Director Whitley mentioned, and I know all the divisions of HHS and many others throughout the state have been working very hard on the COVID response, and we have in the division as well. So kind of a bucketed some of our accomplishments in two buckets, both the COVID and the non-COVID here. So again, as we've already mentioned, our large increase in enrollment, I think by the end of the biennium, that's projected to be a 20% increase over where we were when or before COVID began. We did work rapidly, again, in collaboration and coordination with the federal government to ensure that the program was able to be flexible and rapidly adapt to some of the needs that evolved due to COVID. So we did make some changes to streamline provider enrollment processes to ensure telehealth was available. Definitely wanted to make sure that services remained available, but also wanted to promote social distancing and do what we could to support efforts to slow the spread of the virus. So did open some additional telehealth codes and modalities, made changes to hearings and prior authorization practices. So outside of the COVID response, we did develop a new program to expand coverage options for individuals who are enrolled in both Medicare and Medicaid. That population is often referred to as the dual eligibles, and did work with the Centers for Medicare and Medicaid Services to implement the state's first dual special needs plan, which makes additional Medicare Advantage on the Medicare side options available to the dual eligible Medicare and Medicaid enrollees. We also received, worked with the Division of Children and Family Services to implement a new service array for children in foster care. We received certification for our modernized Medicaid Management Information System, the MMIS, which has been a very large IT project, many years in the making. So have been working to finalize that, and it really has improved the way that we're able to manage claims and provide data, and also recognizing the really critical challenges related to substance use disorders, have been working to improve those services and working to implement the state's Support Act grant. Next slide, please. Okay, this is our overview of our budget funding sources. So here we'll start with an overview of our budget request for this biennium. As was previously mentioned, our overall funding request has increased 25%, approximately $2.3 billion over the current biennium's legislatively approved budget. As Director Whitley mentioned, this largely falls into the caseload increases and inflation increases. Would also note the role of the AB3 rate restorations, which we'll talk about more later, but those are the kind of big buckets that account for our increase in our Governor Recommends budget. There are other changes that are mostly due to the transfer of drug rebates into a standalone budget account, and certainly some budget reductions that we will also go over later, but just did want to provide this high-level overview of our increased request and provide that information that it's primarily due to caseload and inflation costs. Next slide, please. Okay, so we have a series of slides on caseload here, starting with the Medicaid caseload. The Governor Recommends caseload is based on October actuals and November projections. The October 2020 actuals were 752,208 for Medicaid, which again is approximately an 18% increase since February 2020. So here I'll just note that while the caseload is still growing, it isn't growing at the same levels and the same rates that we saw in April, so not quite the same high level and fast growth that we saw immediately following COVID and the public health emergency. So based on the Governor Recommends budget, Medicaid is experiencing increases in a variety of categories. Newly eligible adults is up 25.6% since February. Parents and children is up about 20% since February of 2020. Did just want to point out that these increases are expected in Medicaid programs. They are countercyclical, and when the economy worsens, it is an expected trend that you would see increases in Medicaid caseload, as we are seeing here. Another factor I would just like to point out and highlight is we've already mentioned the enhanced federal medical assistance percentage, or FMAP, that came to the state through the Families First Coronavirus Response Act. And that act also had some conditions that go along with the enhanced funding. And one of those is related to maintenance of effort requirements for eligibility, which effectively required continuous eligibility during the time of the public health emergency. So I would say that, along with the changes in the economy, are two of the factors that are most significant in terms of driving this increase. We do have some additional information on program demographics that we put in an appendix to this presentation. So next slide, please. Okay, this is the checkup caseload. Here again, the Governor's Recommends caseload is based on October actuals and November projections. The October 2020 actuals were 26,593, and just wanted to add that the Office of Data Analytics will be looking at this as we go through session, definitely updating based on latest economic data and revising the projections based on the latest data available. This projection, as they all are, is based on employment data, population growth, and caseloads. And just wanted to note too the uncertainty and volatility that we talked about a lot during special session, and note that the economic data is rapidly changing at this time. Next slide, please. Okay, this chart shows caseload growth for the waivers. Nevada currently has 3 home and community-based waivers that provide supports needed to allow individuals to stay in their homes rather than needing to rely on institutional care. Nevada's waivers provide these services to 3 populations: the frail elderly, individuals with intellectual disabilities, and the individuals with physical disabilities. People getting services at home continues to be a really popular option. I think survey data shows that that is generally the consumer preference, and you can see that in increased and continuous demand for these services. The budget includes both service and administrative costs related to the waivers. Specifically, the division is requesting caseload increases of 239 for the frail elderly, 141 for individuals with intellectual disabilities, and 135 slots for those who are physically disabled. The green section here is the standard anticipated caseload growth, and the orange section on this chart shows the additional slots that are needed to comply with Olmstead requirements and represent what would be needed so that no one waits on the waiting list for these programs for more than 90 days. Next slide, please. This slide has additional information on the federal medical assistance percentage, or FMAP. Again, shows how much of the program is paid for by the federal government. This slide here shows the blended federal medical assistance percentage rates that were used in building our budget. The FMAP rate determines the share Medicaid and checkup, again, that are paid with federal funds. The blended rates here convert FMAP, which is mostly set on a federal fiscal year basis, to state fiscal years. The rows in green on this chart show the impact of the enhanced FMAP under the Families First Coronavirus Response Act, that 6.2 enhancement that we've talked about, available from January 1 to 2020, now through June 30th, 2021. I think Director Whitley did a great job of explaining how this process works and that it's contingent on quarterly extensions of the public health emergency from the Secretary of Health and Human Services. So that's something that we definitely continue to closely monitor, but did want to note that here. Also, the FMAP rates for the upcoming biennium that are shown here are slightly lower than the rates that were budgeted for the current biennium, not including the enhancement under the Families First Coronavirus Response Act. And it seems a little counterintuitive given where we are with our economy today and the fact that FMAP is based on a comparison of personal income in the state compared to the rest of the country, but this is largely due to lags in this data. So the federal fiscal year 2022 FMAP is based on per capita personal incomes from 2017 through 2019, a time when Nevada's economy was growing more quickly than the rest of the country. And we will, in further out years, start to see the impact of the current slowdown on FMAP, and that will be realized in federal fiscal years 23 through 25. Next slide, please. This slide shows our budget accounts for the department. There is a new budget account that I wanted to note and highlight here that is 3245, and that is the prescription drug rebate, which is now a new standalone budget account. This had previously been included in our Nevada Medicaid budget account in the offline category, but due to conversations with the legislature in the prior session, we have developed this new budget account to provide additional transparency in terms of prescription drug rebates. Next slide, please. The next part of this presentation will include a discussion of the highlights of our requested budget. We have kind of 4 big categories here: mandated changes, position transfers, budget reduction initiatives, and enhancements. So this slide here focuses on the mandates. We do have two mandates from the Centers for Medicare and Medicaid Services. The first is related to interoperability. CMS does mandate interoperability, which in, I think, layman's terms, the way that I understand it, is that it means that different information technology systems and software applications have to be able to communicate with each other to improve the electronic exchange of healthcare data. We do that through what is called application programming interfaces, or APIs. Importantly, this also allows patients greater access to their health information, and that has been a big push by CMS and required by a recent federal rule. So we are working to meet those federal regulatory requirements related to interoperability. The next is electronic visit verification, or EVV. This was actually required under the 21st Century Cures Act. So it's also mandated by CMS for all personal care services and home care health services that require an in-home visit by a provider. The purpose of EVV here is to ensure that patients are getting the care for which Medicaid is being billed and to help verify those services. I did just want to highlight this as an area where Nevada Medicaid has really excelled and received some national recognition from CMS. Always want to highlight the great work that has been done by our team, and just want to note that I've actually been able to implement some of these requirements. They're not all, and we still have work to do ahead of federal deadlines. And just wanted to note that this is a place that our team has gotten national attention and requests for advice to other states on EVV implementation. Next slide, please. This slide outlines the position transfers that we're seeking in this governor's recommends budget request. We are requesting position transfers really to build and enhance the clinical capacity that we have within the division. Know that that is so critical to our ability to make good and evidence-based policy decisions. So I'm really looking to formalize great work that has already been done by the state dental officer and the senior advisor for pharmacy. So seeking to move those positions from public and behavioral health to DHCFP. Again, those positions have both played critical roles in helping to advise Medicaid and policy development, assisting with the development of a comprehensive strategy for prescription drug coverage, also helping with our dental managed care product. And this change, I think, will just really help formalize that relationship. I would note that there is also a budgetary advantage to the state in terms of making this transfer. If these positions do come to DHCFP, they will be eligible for 50% administrative match from the federal government. The next series of positions are related to auditing activities. These three transfers are being requested. We really feel like the work of these positions is in better alignment with the work that the Aging and Disability Services Division does in terms of quality assurance. It's really a little bit of a different task than the traditional surveillance and utilization review activities that DHCFP routinely conducts. So we just think that that will help simplify the processes and organizational structure and lead to better monitoring of providers. Next slide, please. Okay, the table here shows much the same information that we just went over, but this shows that with the addition and transfer of the staff mentioned in the last slide, the division will be down one position. That's technically the case, but the dental officer is a contracted position currently. And so with that one included, as if it were a state position, the numbers would be even, and we wouldn't even be down that one position. But to just want to note the current that's not a state position currently, it's a contracted position. Next slide, please. The next two slides provide information on the division's proposed budget reductions. The slide outlines the services that the division is proposing to eliminate or reduce to meet the current budgetary challenges. I did want to note that this is a little bit different than what we talked about during special session. Had a lot of conversations at that point about the requirements of the Families First Coronavirus Response Act and how it was kind of uncertain how CMS would react to states trying to make changes to services. Since that time, CMS has issued additional guidance that has clarified that these types of service reductions are allowable under the terms of the Families First Coronavirus Response Act. So these types of changes are allowable without putting that enhanced FMAP at risk. So just did want to flag this because it was a little bit uncertain during the time of special session. And since that time, additional guidance has come out from CMS to clarify this issue. So the particular services here have been identified, and I certainly want to acknowledge that elimination of any services will lead to a reduction in the broad availability of services overall. But here, these were selected largely. These services aren't covered by commercial insurance, and it's just part of an effort on the part of the department to raise the level of care and efficacy of services, trying to ensure that the services provided are really in alignment with commercial insurance, and also to make sure that we are funding evidence-based services and ultimately promoting better health outcomes. Next slide, please. This slide provides an overview of some of the financial budget reductions. I think some of these were alluded to earlier during Director Whitley's presentation, but these financial reduction requests would allow the state to carry forward a surplus that currently exists in DHCFP's current budget and to make payments from this budget year to offset some of the need for additional reductions to the program in the upcoming biennium. Additionally, the managed care risk corridor that is highlighted here would ensure that the payments to managed care appropriately represent costs. So I know that was something of great interest, and we can certainly provide additional information on that, but did just want to highlight these as kind of the financial initiatives that we are putting forward to try to carry forward some funding that exists in the budget now and reduce the amount of other reductions that are needed to the program. Next slide, please. Okay. This slide provides an overview of our program enhancements for the upcoming biennium. The first of these is AB3 rate restorations. Again, I know that this one has already been the subject of some questions, but really excited, as I am sure the legislature is as well, to be able to restore those rate reductions to the provider fee schedule that were required during the special session to deal with the economic crisis and required under Assembly Bill 3 that was passed during this 31st legislative session. So we are requesting funds to restore the 6% provider rate reductions that we're working to implement as a result of the state fiscal crisis. The next program enhancement listed here is related to changes in the Katie Beckett program. This would really standardize the parental financial obligation on a tiered scale and move the service calculations for the parental financial obligation, which I think of like a premium. It's not exactly, so I know there's some nuances there, but just to give you a sense of what this is, moving that parental financial obligation from a quarterly to an annual contribution, that helps us stay in alignment with federal requirements, and we think has benefits for consumers and families served by that program as well. The certified community behavioral health centers here, we are seeking an enhancement here to fund technical assistance and data analysis that's required for the quality incentive payment. That is a part of the CCBHC required under the state plan, and just some technical, like, financial and actuarial assistance is needed to make sure that that program is being stood up appropriately. The next two enhancements listed here are related to supplemental payment programs. The first is the IAF County Match Program. I know Director Whitley touched on this one as well in his presentation, but this request supports the Nevada Association of County Organizations, NACO board decision to divert the 1.5 cent ad valorem tax receipts to assist the counties with funding the long-term county match program. The county match program has increased significantly, and this request would provide some relief for that program. The division seeks to improve access to services through the county match program. And again, this helps the county with their long-term care obligations to manage the costs of that program. Does, as Director Whitley mentioned, have implications for hospital supplemental payment programs as well. But this is requested to stay in alignment with that board decision that was made by the NACO board. The next is a directed payment program. This program would benefit county hospitals and provide flexibility in managed care for supplemental payment programs. Historically, those have only been done through fee-for-service. This directed payment program seeks to add a supplemental payment program for large county hospitals through the managed care program. Next slide, please. This slide outlines some of the enhancements related to transparency in our budget. Division is making changes to be more transparent in a number of ways. First, we are putting drug rebates into a separate budget account, as was previously mentioned. Second, we're seeking authority to eliminate a non-transparent third-party contract, instead moving to funding a direct contract held directly between the division and a vendor for fee-for-service management of the pharmacy benefit. And lastly, to fund a vendor to review the medical loss ratio submissions by managed care organizations. The last one, the request related to the medical loss ratio, that's a requirement that limits the medical loss ratio is a requirement that limits the portion of premium dollars health insurance may spend on administrative, marketing costs, and profits. And that is capped at 85% of costs that must be spent on patient care and services, and the remainder on those administrative costs that I mentioned. But in the last couple of years, CMS has provided additional guidance on how MLR is to be calculated and audited by the states. And it's really increased the complexity of the MLR calculation. So the division is seeking technical assistance from an external vendor with expertise in this area to help ensure that the plan submissions to the state are accurate. And again, this is important because if the plans fall below that 85% level, they would be required to remit funds back to the state. So just wanted to highlight that as part of our transparency efforts. Next slide, please. These enhancements are all related to information technology. Here, the division is looking to enhance IT systems by consolidating data systems, again, modernizing our information systems, and improving access to information by hiring a position to improve data quality. That's the TMSIS data quality bullet at the bottom of the slide. And TMSIS has really been a high priority of CMS now for many years. It enables them to get better data from states and also to make comparisons across states by having uniform and standardized data. So they're really incentivizing and encouraging this type of commitment and investment in the TMSIS data quality program, and are funding those positions at 90% federally funded. Okay, I believe with that, our presentation has concluded, and happy to address any questions the committee might have.
Thank you very much, Ms. Bierman. I'm sure there are going to be a number of questions. So what I'll do is I'll open it up to the committee, and then what they don't cover, I'll go back and be the cleanup hitter if that'll work for everyone. So Dr. Titus, I'm just going to go to you automatically.
Thank you, Madam Chair. I very much appreciate it. Thank you, Administrator. I definitely appreciate the high-level view. It's a complicated process, to say the least. So putting this in a short presentation is challenging. I have several questions. I'm going to start with the FMAP rate would be my first one. Director Whitney mentioned that it goes through June. I know that it's in quarterly increments, and I know that during the special session, we had hoped it would go through September. I heard him say June. Have we gotten that it would go through June at this point, or is unclear?
Thank you for the question, Assemblywoman Titus. Yes, we have, just in the beginning of January, Secretary Azar did announce a further extension of the public health emergency, which extends the enhanced FMAP through the end of this current fiscal year, so through June 30th.
Excellent, thank you. And then my next question is, on your presentation, apparently you're going to make one of the arguments or one of the cost savings is to make certain payments to the managed care organizations in FY 2021 rather than in 2022. My concern is with that is, what rate will you be paying them at? We have definitely an increased enrollment, and we pay per enrollee, but I know that we're renegotiating some of those costs. So will that be at the current rate that we're paying? And why not wait until we renegotiate the cost to then make those payments, especially with the numbers that we have right now?
Excellent question. Thank you, Assemblywoman Titus. And I'll start and, definitely have backups and reinforcements, both from our finance deputy and our team in Carson. But those particular payments, I believe, are separate from the capitation payments that you're mentioning. We do, in addition to the capitation payments, which is the monthly per member per month, under the terms of our contract, have additional payments that are non-capitated in nature that we make to the managed care organizations. And a couple of examples of that are things like pregnancy kick payments and extremely high cost patients. There's a stop loss provision in the contract, and also I think some other payments that aren't capitated, the per member per month, but are I think pregnancy kick payments is one of them. But we do have a discrete number of additional payments that we make to the managed care organizations under the terms of our contracts with them that are separate from those capitated monthly payments. And I think that's what we're seeking authority to pay from this year instead of extending into the next year. And I think during the special session, we didn't know that we would have the further extensions of the public health emergency. And it was something that we had proposed to delay in order for cash flow purposes. And I think now, that we have some surplus in our current year's budget, kind of similarly are seeking authority to pay that out of existing funding rather than paying that in the next year. But I think to your point, to your question, the important point is that these aren't the set amount of capitated per member per month payments that we make to the managed care organizations.
And when will we look at renegotiating those capitated rates?
So we're actually working on that right now. We have a couple of avenues that our managed care team and our rates team are working on with the managed care organizations. Certainly, they've been involved in the 6% rate reductions that we've been working on. The managed care team and the finance team have also been working on something that is called a two-sided risk corridor. So all this gets really pretty technical pretty quickly, but I'm happy to provide additional information on this. But that's basically a risk mitigation strategy that is intended to promote accurate premium payments. And this is one of the strategies that CMS has offered to states and really encouraged as a way of getting to this issue that you're raising, which is completely valid around ensuring that the amounts that we've paid to the managed care organizations accurately reflect cost and are appropriate premiums during this unprecedented time of COVID that no one could have foreseen. So our managed care team is currently working to get those implemented, and that's one of the ways that we'll make sure that the premium amounts that we pay are accurate. So that is currently ongoing.
And then when you present that to us further on, when we break down this in our subcommittees, I think showing the lanes of folks that are on the numbers that are capitated and those enrollees, and then teasing out, because some of the enrollees that are capitated in managed care may need other services that aren't capitated. And so they can have those dual lanes and maybe have dual services. And as I think as Director Whitney mentioned early on in his presentation, rarely does an enrollee just need one service. Rarely is there just one issue that they have. So I'd like to see maybe some of those other, so the numbers will be somewhat confusing, I think, at times. So it's important we know that they could have both an enrollee that's capitated, but also be perhaps on a maternal needs or something else that's not capitated. So that would be good information. Then my third and final question is on your graphs that show the enrollees, and you show that obviously the huge climb after the COVID hit, and now we're really kind of flattening that curve. Yet we're still putting more money in based on the fact that we might have an additional enrollee. Certainly not compared to what that huge spike was, and everybody gets why that happened. I'm just wondering if it's really, since it's probably going to drop a little bit, where the determination of the increase in funds came from, and is it just trying to backfill what the anticipated needs are because of those additional enrollees? I know that's a long question but I'm just concerned about the fact that it's a good thing. It's a good thing that we're going to flatten that out. So I just wondered if it was like a backfill that we're doing, or we haven't caught up.
Yep, I think some of that is, a little uncertain, and the Office of Data Analytics, which Director Whitley mentioned, I know will be working throughout the session to update those caseload projections, but a lot of it really does depend on the economic recovery and how quickly that happens. And if we've seen the full surge in Medicaid enrollment, certainly our numbers suggest right now that we saw much higher levels early on in the pandemic. We know from prior recessions, though, which, I think part of this is how similar is COVID to anything that we've seen before, and how different is it really? Certainly see people taking care of things like food and housing needs before they always get to their health insurance needs. And also, we know that some employers have been able to hang on to providing employer-sponsored insurance through this period. And so I think a lot of it just depends on how quickly the economy rebounds, and if they're able to continue to preserve those employer-sponsored insurance provisions. I think at the federal level, this is all rapidly developing too. There's been some talk, I think, in the new COVID package of potentially providing some COBRA assistance for that type of employer-sponsored insurance. So I think it's just going to really depend on how we see those trends play out. And I know the Office of Data Analytics does update all of this at some point, I think March or April, during session.
Along those same lines, when we're seeing that curve, what we're going to want to see, at least for myself and I'm sure others, are, we've given a lot of bus passes out, but have we given them any more buses? In other words, I'd like to see what your enrollment in providers are, and if you've expanded that accessibility, because again, one of my concerns is they think they are insured, and then when we go to look for a provider, there's no providers out there. So we're going to want to see that, at least I am, and I'm sure others will want to make sure that you're also, what are you doing, and different conversation, what are you doing to, and certainly restoring that 6% will be help, but how do you get them access to care. And I'd like to see that curve of increase in providers go up too, based on some incentive for providers. So again, there's a lot of stuff, and I know we're not in the weeds today, but I appreciate you answering the questions that you could, and look forward to further dialogue. Thank you.
Okay, and thank you, Dr. Titus. Along that line, I want to go ahead and ask Ms. Bierman. We were talking about that curve, and I don't remember which slide it was, but it was definitely going up the Matterhorn there on Medicaid caseload. And I know Dr. Titus had just mentioned she was hoping to see it flatten and possibly go down. But I do know that at the end of February, there's going to be, I believe, around 30,000 folks that their health insurance is going to expire at the end of February, depending upon where we are then. So were you aware of that number, Ms. Bierman? And what impact do you see that having on that curve that we've got for Medicaid caseload?
Thank you for the question, Madam Chair. We certainly have been having conversations with large employers in the state. Again, I think the reference earlier to continuation of employer-sponsored insurance throughout this period, knowing that at some point that's not something that is likely to be sustainable without improvements in the economy broadly. So we have been having conversations and are prepared to do everything that we can to assist in, along with our partners, of course, at Division Welfare and Supportive Services, doing everything that we can to make information about Medicaid known, that there is no open enrollment period in Medicaid. So it's different than, commercial insurance and insurance available through the exchange, and providing assistance in terms of getting information out related to enrollment and the services provided. So we are aware that some of that is likely, and have been working to try to make that a smooth transition for Nevadans as they need coverage under this program.
Thank you very much. I do have a queue of folks who do have questions. So I am going to go to Ms. Tolles first. I believe I had her first.
Thank you so much, Madam Chair. And I think this is, more of a question that as we dive deeper into this, I'd like to unpack a little bit more. When I'm looking at slide 17, and the programs that we're reducing or eliminating, particularly eliminating basic skills training, psychosocial rehabilitation, and biofeedback neuropathy services. As I went back to some of the original intent for those programs, it was to help to get people as highly functioning as possible to reduce the need for so much expansion of the Medicaid and government services. And so I wonder, are we replacing that in some other category, or is there some reason, you mentioned evidence-based when you got to that point in the presentation, is there some reason that we have evidence that those programs were not as effective and we're replacing them with something else? Because I don't want to lose that goal of helping people to, be as functioning and successful as possible. And that's my understanding of what those particular programs were designed to do. And that may be a further discussion, but yeah.
Yeah, we'd be happy to provide further information on this. I know our team has done a deep dive and evaluation into these services. I will say, there's always impact with the elimination of any service, but there will continue to be other behavioral health services that are available, including assessment, diagnosis, peer service support, crisis intervention, a whole slew. Certainly, we take our commitment to ensuring behavioral health services quite seriously, and happy to provide additional information on the type of evaluation that went into these decisions later, and as we get more into the weeds of all of this. But did just want to acknowledge that there may be issues with continuity of care, but we do think that there's some likely transitioning from these services to other behavioral health supports.
I appreciate that. I appreciate that we'll be able to dive into this deeper. I just wanted to give you perhaps a heads up that that's something that I may be interested in, because we know that oftentimes when we take a more holistic approach to both healthcare and behavioral healthcare and to work-life balance issues, that it ends up reducing costs and the burden over time. And so I heard you say some of the other behavioral healthcare that we're still keeping in place, but it sounded like those were more acute care responses as opposed to that more holistic model that in the long run we get that return on investment overall and a reduction in needs. So appreciate that. That's all I have to say. Thank you, Madam Chair.
And thank you, Assemblywoman Tolles. And I did have questions along the same lines. So my question would be, is how involved were the families in discussing this? I know jobs and day training are very important to some of our folks in our community. It's where they get to go every day. It gives them purpose. It gives the family a sense of normalcy. So I'd really be interested in how much we talk to the family, any reactions. Honestly, this session, we don't need a bunch of angry families walking in the door, wanting to know what happened to the program that supports their adult child that might still be at home for some reason. My other concern is that the reductions, I want to make sure that we get a real evaluation of what's general fund and what's federal. You know, in special session, we talked about, yes, we can save some general fund, but how much federal money are we going to be losing? So I've done some basic math on that, but we'll dive deeper into that when we get into the subcommittee. But I just wanted to give you a heads up on that. And we really want to know how this is going to affect the families of the state. So thank you very much. Just wanted to let you know. The next person I have is Majority Leader Benitez Thompson.
Thank you, Madam Chair. And two of my questions are, I'll probably end up directing them more to aging and disability services, since we're talking about money and funding for caseloads and program, but the dollar piece here, but then the programs are actually run and managed by ADSD. So I think as I look at it, I'll probably ask them the questions, and it's going to be specific to waiver slot increase, and then back where you guys are budget reductions, but more specific to personal care services. So I'll ask him on the program side.
Thank you, Ms. Benitez Thompson. I believe I have Senator Kekepper next.
Thank you, Madam Chair. I appreciate it. Ms. Bierman, thank you so much for the presentation. It was, as always, excellent. I had a question about the hospital rate reductions and then restoration. Were those reductions ever actually implemented?
Thank you for the question, Senator Kekepper. We are working to implement those changes. The process with CMS has been quite lengthy, and started this process just as soon as we got out of special session, have submitted all of our state plan amendments. CMS does have this ability to do what is called stop the clock. So when they issue a request for additional information, it stops the amount of time that they have to make a determination either in favor or rejecting a state's proposed amendments to the state plan. That is currently where we are with CMS. So we have been working to submit all of the state plan amendments. Our finance and rate team has done a tremendous amount of work going back and forth with CMS, trying to address any of the questions they have around the rate reduction. So we haven't yet pulled the trigger because we don't yet have approval from CMS, but did submit it in a way that would allow, assuming CMS approval, to retroactively reduce those rates back to August 15th. So, we're trying to communicate all the information that we have to providers to help them understand where we are in this process and to be ready for those rate reductions. We developed a frequently asked questions document that we'd be happy to share with the committee. But right now we're in the process of implementing all of this, but can't actually pull the trigger on any of it until we have that final approval from the Centers for Medicare and Medicaid Services.
So are you still making payments to hospitals now under the old rate schedule, or are all payments at this point on hold?
My understanding, and I'll invite the finance experts from our team to clean any of this up if needed, is that we are still paying according to the prior rates, and really just trying to educate providers about the fact that these rate reductions will be coming and that they will be retroactive. We've had many conversations with hospitals in particular around the actual process for making this happen, and have tried to get feedback from them and their members, realizing that none of these are really great options, but just trying to work with them to, one, keep them up to date, and two, to the extent that we do have flexibility in terms of how we operationalize this, getting information and feedback from them.
And then I know the restoration is effective October 1st. Is there a reason you picked that date rather than the start of the fiscal year?
Again, my understanding is that that's the amount of time that's needed to make the numbers work, but we'll see if anybody from finance has a different or more detailed explanation. But I really think that was the basis for that particular date. That many weeks of the restoration were needed to meet the financial reductions.
And we'll dig in some more, obviously, during subcommittee. The other question I had, it sort of tails along with your caseload projections, right? I mean, your caseload projections for Medicaid really show no economic recovery, which is sort of contrary to what we see in sort of our tax projections and sort of economic forecasts, particularly in 23. And also your blended FMAP for 23 goes up a percentage point, which would usually indicate that our economy is doing we're less well off than we were the prior year. Is that just a trailing indicator, or why would our FMAP rate be going up when we're expecting an economic recovery, or does your division just not see an economic recovery in 23?
I think related to the FMAP rates, that is related to the kind of time lag. I'm trying to find what slide had that specific information on it. Can follow up with that. But I do know that there's a delay in what you're actually feeling on the ground, and where your FMAP, if it's higher or lower, because there's a time delay. So it looks like here where we are is based on per capita personal incomes from 2017 to 19, when Nevada's economy was growing faster. And currently, we know that Nevada is among the states most hard hit. And so we will expect to see that impact in terms of the feds paying a larger share of Medicaid costs in 2023 to 2025. And happy to get additional information. The Office of Data Analytics is really the office within HHS that produces all of our caseload projections. So happy to work with them to get additional information on all of the different factors that go into producing their projections.
I appreciate that. Thank you, Ms. Bierman. Thank you, Madam Chair.
And thank you, Senator Kekeffer. And I was looking at some of the same things, and I know there is a list out there of the major industries that have a number of employees that do receive Medicaid. So I don't think an economic recovery actually translates into affordable health care. So I think that's another issue that we're probably going to need to dive a little bit deeper into the industries that are actually, the state is subsidizing those employees for their health care. So with that, I believe I have Senator Ratty next.
Thank you, Madam Chair. I appreciate the opportunity. Following up a little bit on Senator Kekeffer's questions about the timing around the 6% cuts, Medicaid rate cuts, is the reserve budget built on the assumption that we get approval for those cuts going back to the August date of implementation?
Thank you for the question, Senator Ratty. I believe the answer to that is yes, but I do want to reach out to our finance team to confirm or correct that one.
Okay. My question is if we're in a time freeze with CMS, and part of your plans include using Medicaid reserves as cash flow to pay some payments to MCOs in this budget cycle. If we've been paying the if we've not been gaining the benefit of the 6% rate during this biennium, from a cash flow standpoint, if we're going to have the cash to do the advanced payments in this biennium, if we don't get that approval from CMS in a timely fashion. And the follow-up answer is
Thanks
fine.
for your. Okay.
Morning.
Thank you.
This
And I
is
did
Phil-
get.
Sorry. Go ahead, Suzanne.
No, go ahead, Phil, please. Thank you.
Oh, sorry, this is Phil Burrell, fiscal deputy here for the division. Just to follow up Suzanne's question, the answer is yes, that is reflective.
And if CMS drags their feet in terms of getting us that permission, will we still have the cash flow to do the advanced payments that are anticipated in the governor's budget?
Good morning. Good morning. This is Melissa Locker Lewis here in Carson City. So Senator Reddy, the answer to your question is potentially with the extension of the public health emergency and the additional FMAP, we would still have some funding. However, it may be a close call. We are monitoring that on a daily basis, though.
Thank you. Thank you for the opportunity, Madam Chair.
Out and asked about a question.
Madam Chair, you're on mute.
Madam Chair, you're still on mute.
I think the host muted me and I did not realize it. Thank you. So with that, are there any other questions from any other committee members at this time on these particular issues? And again, we will be diving much deeper as we get into the subcommittee world on this. So thank you very much, Ms. Bierman. We appreciate you being here. I believe committee that us, we're pretty much doing well on time. The plan is to go through the Division of Welfare and Supportive Services and then break for a lunch break. Not necessarily for us as much as for all the staff and all the other folks out there that are waiting for us to get our work done. So we want to be able to give folks a little bit of a break at the lunch hours. So with that, I believe we can go to Welfare and Supportive Services. And I believe I have Mr. Fisher available to start us off.
Good morning, Madam Chair. For the record, my name is Steve Fisher. I serve as the administrator for the Division of Welfare and Supportive Services. And first of all, I want to thank you for this opportunity to present our governor's recommended budget. With me this morning, I have a couple of co-presenters. To my left is Robert Thompson. He serves as the Deputy Administrator of our field operations. To my right is Joe Garcia. He's the Acting Deputy Administrator of our field operations support. I also have in the room with me our Chief Financial Officer, Brenda Berry, and our Chief IT Manager, Barb London. Let's go ahead and fire up the presentation. Madam Chair, are you able to see the presentation?
Yes, I am. Thank you very much, Mr. Fisher.
Great. Next slide, please. Slide 2 is the mission statement for the Division of Welfare and Supportive Services. Next slide, please. Slide 3 is our organizational chart for the division. Next slide, please. Slide 4 is our agency operations, and I'm just going to spend just a few minutes just giving a high-level overview of what we do and how we do it. Our agency certainly is broken down into 5 operational areas, plus our administrative services. And what we do, we provide public assistance to all who qualify. And we do that based on determining eligibility for the Temporary Assistance for Needy Families Program, Medicaid program, Supplemental Nutrition Assistance Program, Energy Assistance, and the Child Care Program. And how do we deliver these services? Well, approximately 6 years ago, we moved from what's called a case management business model to a task-based model. So instead of assigning a set of cases to an eligibility worker, tasks are added to a queue, and anyone who has access to that queue can pick up the next task and work the case. This business model significantly improved productivity, so much so that we reduced the number of positions during the last 2 sessions, even though our caseloads were projected to increase. And I believe that was approximately 103 positions that we reduced our division by. The increase in productivity also provided us with the opportunity to create what's called our targeted outreach team, where we place staff into non-traditional locations, like, for example, the Clark County Detention Center, Washoe County Detention Center, hospitals, for example, to provide access to our services. Certainly, our outreach staff are not as productive. However, having access to our services in non-traditional locations really does outweigh the little bit of loss in productivity. Also, because of the increase in productivity and the capacity we gained, we were able to move eligibility workers to our call center. So we're able to process eligibility over the phone. I'm very thankful that we certainly have the technology to support our business model, because it provided us with flexibility to move to a remote business model very quickly when the pandemic lockdown occurred, and our division continued providing services. Certainly, this new business model has improved employee morale, and most importantly, has improved our customer service. And just speaking about employee morale, back in September, we put out a request for volunteers. We were looking for 200 volunteers to work over at the Department of Employment and Training and Rehabilitation to help them with their backlog of UI claims. We had an overwhelming number of staff who volunteered, over 400 staff who wanted to help. Those 200 staff have been working over at Dieter since September. They processed over 86,000 claims, and they've been doing it working overtime. So great job, staff. Next slide, please. These are the division's priorities for the next 2 years, and I'll just briefly summarize them. The first one is continuous improvement to customer access and program integrity, creating opportunities for increased self-sufficiency through our employment and training programs and child support. The third one is improving efficiencies through technology across the entire department. And last, seeking collaborative opportunities to enhance customer service. Next slide, please. So, huge list of accomplishments. I just want to thank our staff for all of their hard work and dedication over the last 2 years. I want to thank this committee for your support last session. Many of these accomplishments would not be possible without your support. I'll just briefly mention a couple of them. I think important to this committee is TANF. We did meet the all-family work participation rate for federal fiscal year 2019, and I will discuss that in further detail further on in the presentation. Child Care Development Program, approximately $33 million in CARES Act funding was distributed, increasing child care availability from 34% in March to 90% in October. Targeted outreach, I mentioned that team. We increased access to our SNAP, Medicaid, TANF, and our workforce development, serving 129 community partner sites, and also we attended 64 specialized events with 35 case managers. And lastly, our call center. Case managers answered over 40,000 calls per month during August through October of 2020. And if you compare that to 2019, they were taking 18,000 calls. So a significant improvement there in our call center. Next slide, please. Slide 7 is just a budget comparison of our current budget to the governor's recommended budget. We're looking at about a 12.5% increase over our current budget. Next slide, please. Slide 8 is our biennial budget request. It's really broken down by the different budget accounts. Next slide, please. Now we're moving into our caseload projections. Certainly caseload drives our business. And as we look back over the last 9 months or so, there have been many variables such as waivers, pandemic programs, additional UI benefits that have not only impacted the caseload, but also the number of client actions or tasks that our staff need to accomplish. Certainly, as I step through these caseload projections, just remember that they're based on November's data. And certainly, as we move forward, these caseloads are definitely going to change. So I'll start with the Temporary Assistance for Needy Families program. This program is designed to care for dependent children in their homes or in the homes of relative caregivers. The program is for low-income families, provides financial support services such as childcare, transportation, and it focuses on the whole family's well-being, including children's immunization, and at the same time working with the parents to gain or enhance work skills, education, and employment. The TANF program serves families with minor children with income below 130% of poverty level. An example of that, let's just take it, for example, a single household of one, 130% of poverty would be $1,382. We look at a household of four, it would be $2,838, just to give you a point of reference at the poverty level. TANF caseload is projected to decrease about 6.25% in the upcoming biennium, and that's from base year, state fiscal year 20. Our caseload peaked in May of this year at about just over 23,000 and has been decreasing since. And we believe that that's based primarily due to the unemployment insurance benefits. I think it's important to update this committee on our work participation rate and penalties. There are two work participation rates that we are required to meet. The first one is what's called the two-parent work participation rate, and that's 90%. The second one is what's called the all-family work participation rate, and that's 50%. The division has been penalized just over $20 million due to failure to meet the two-parent work participation rate going back to 2007, and failure to meet the all-family in 2007, as well as 2012 through 17. The division, however, successfully met the all-family in 2018, and we entered into a corrective compliance plan for 2019 in an attempt to reset the penalties for years 2012 through 2017. I am excited to report to the committee that the all-family work participation rate was met in 2019 with an unprecedented overall all-family rate of 60.10%. While DWSS has not met the two-parent work participation rate goals, the majority of the penalties is due to the not meeting the all-family rate. The division is pending notification from ACF regarding the corrective compliance plan, but we expect the outcome to be favorable, waiving an estimated $18.5 million of those penalties. We did provide a TANF source and use in our appendix on slide 27. We are projecting to have a remaining grant amount of $31 million at the end of the biennium, and a 90-day reserve would be approximately $12 million. Next slide, please. Administrator Bierman did a very good job of providing what the Medicaid program does and what the impacts have been to the Medicaid program. I would just like to add a couple of things to what she had brought up. In addition to when we talk about the enhanced FMAP, really one impact to our agency is the fact that we cannot terminate anyone from the program with exception of, say, a voluntary withdrawal, or if someone moves out of state, for example. So it's been a lot of extra work for our staff to make sure that they don't terminate any of the Medicaid cases. Also, we were provided with some flexibility to extend processing timeframes. And so we have, since the beginning of March, been pushing redeterminations out 6 months into the future. So each month, when redeterminations are due, we push them out 6 months. And we've been continuing to do that month after month. And again, that's a lot of work for our staff. Next slide, please. The Supplemental Nutrition Assistance Program is federally funded and helps qualifying low-income families or individuals buy nutritious food from local retailers. SNAP serves families and individuals with income below 130% of the poverty level. Our SNAP caseload is projected to increase 7.26% in the next biennium, and that's from base year state fiscal year 20. I'll just cover a few impacts to our caseload and our workload for the SNAP program. We had a statewide called ABODs, able-bodied adults without dependents. Those are individuals between the age of 18 and 50, who have children in the home and not working 20 hours per week. That's the definition of an ABOD. And we had a statewide waiver, with the exception of Washoe County. It was scheduled to expire in March of 2020. However, because of the employment rate, we were granted a full waiver through this upcoming June of 2021. And we do not anticipate the ABOD requirements in Nevada through 2023. We'll continue to request a waiver. Now, what does this mean? That it means that approximately, or it's estimated that approximately 33,400 ABODs have continued to receive SNAP benefits. Fluctuations in federal assistance, such as the $600 a week and additional CARES Act unemployment benefits, certainly has caused fluctuation in the SNAP program. The $600 per week of additional CARES Act UI benefits was countable on SNAP, while the current benefits are not countable for SNAP. The rules of what income does and does not impact the SNAP benefit is determined at the federal level, which with each of those changes causing increased tasks and change updates for our staff to complete. A couple of pandemic programs that were provided or options that the states could actually take advantage of. One was called PEBT. PEBT are SNAP benefits to replace the free and reduced lunch from last school year. So children obviously being homeschooled or being at home, not in the school, they're not receiving the lunch or breakfast. So therefore, these were benefits to replace that. Really has no impact on the overall caseload size. However, we did release approximately $96 million in additional benefits to Nevada's children, for both children who are on the SNAP program and children who are not on the SNAP program. It's just children who are eligible for the free and reduced lunch program. This is just another example of additional tasks for our staff. And we provided this benefit to over 330,000 children. And this program continues for this current school year. So we are currently working on the PEBT program for this current school year. Another program was called the SNAP Emergency Allotment Program. This increased all households up to the maximum household allotment amount. This has been accomplished for the months of March through December. Over half of the SNAP households saw an increase of approximately $26 million of additional benefits per month. And yet again, this is just another example of a successful program with additional tasks for our staff. And the recent, just one more item, the recent COVID-19 bill really provides a 15% increase to SNAP benefits through June of 2021. Next slide, please. This is our Aged Blind program, which provides a small supplemental payment for aged blind or group home residents who are supplemental security income recipients. Supplemental state payment is added to the recipient's federal SSI benefits so that they are better able to live independently. And this caseload is projected to increase. Next slide, please. The Energy Assistance Program. This program assists qualified low-income households with home energy costs. The Energy Assistance Program serves Nevada households who have gross incomes not exceeding 150% of the federal poverty level and are responsible for their home energy costs. The Energy Assistance caseload is projected to increase 26.4% in the biennium from base year, state fiscal year 20. Certainly the CARES Act funding that we received for the Energy Assistance Program in 2020 really allowed the program to issue supplemental benefits in 2020 and also address the increased energy costs incurred by households during Nevada stay-at-home order. These funds also allowed the program to maintain the benefit level in this fiscal year. Impacts to this caseload, well, the additional federal funding provided through things like unemployment. There were a lot of community programs for utility assistance. And all of these federal assistance programs provided additional resources to Nevadans and certainly had a negative impact on the program. We just weren't receiving applications for a period of time there. However, now that the NV Energy, for example, has lifted the moratorium, we are starting to see an increase in requests for arrearages on the program. Next slide, please. Child care program assists low-income families receiving temporary public assistance, and those transitioning from public assistance and obtaining child care so they can work. The population this program serves are families under 130% of the federal poverty level. The child care caseload is projected to increase to about 1.1% over the biennium, and that is based on the state fiscal year 20 again. This caseload has grown from about 6,000 children in 2016 to over 10,000 children in 2020. Some of the impacts to this particular caseload I'd like to point out, if we just go back to March of 2019, we raised the subsidy reimbursement rate to providers. Certainly, whenever you raise the rate to providers, that means fewer children can be served on the program based on the funding. And we do estimate that this program can serve approximately 7,000 children, and we can sustain that number going forward. Another change to the program was a 12-month continuous eligibility for children. Therefore, you could not take a child off the program for 12 months. They were guaranteed a 12-month eligibility process. And so we tracked the funding. We took a look at the caseload at the time, and in just about a year ago, December of 2019, we placed a wait list on the program, and the primary reason for that was to reduce the flow of children coming on the program, to align the caseload with the funding. Just one thing I would like to note with the wait list, it does not prevent access to enrollment for prioritized populations like those individuals who are on our TANF employment training program, homeless, foster, or Head Start. And then in March of 2020, COVID hit. A lot of changes to the program, temporary changes to the program. For example, redeterminations were waived temporarily so that essential workers continued to work. We made temporary flexibility and eligibility criteria for those that lost their jobs due to COVID. We continued to make payments to subsidy providers regardless of whether the child was attending or not, and the primary reason for that was to really to sustain those providers in the child care industry. Just over the last several months, though, the caseload has been decreasing quite significantly, and we believe that that's due to, number one, parents are keeping their kids at home. Certainly social distancing in those facilities has created less capacity in the provider facilities. So those are just a couple of reasons why the caseload has been decreasing. The current wait list is just over 3,400. And certainly as we move forward, we will be paying close attention to this caseload. We provided a child care source and use in the appendix on slide 28. We are projecting to have a remaining grant amount of $2 million at the end of the biennium based on the caseload. If we project a 90-day reserve, A 90-day reserve would be $23 million. And at this point in time, I'll turn the presentation over to co-presenter Robert Thompson.
Thank you, Administrator. Good morning. For the record, Robert Thompson, Deputy Administrator of Program Field and Operations. While our division has many programs, slide 15 shows what we call our big three, our SNAP, TANF, and Medicaid. And as we've heard many times today, most of our customers access more than one program. And this is a fantastic visual that shows how many of our customers are on more than one program and the different programs they're accessing. It's also notable that our SNAP program is increasing to a point that we are just under 500,000. Next slide, please. Slide number 16, Administrator Fisher spoke earlier today about our new staffing methodologies. And this slide is just a picture of that staffing methodology. Our staffing standards are servicing over 800,000 recipients participating in more than one program. And we are generating 192,000 tasks per month to service those customers. In our agency, 59% of our staff are processing those eligibility tasks, with the rest of our staff here supporting those eligibility workers. Tasks are taking approximately 41 minutes to complete. And if you were with us last session, you'll notice that that is a significant drop in how long our tasks are taking. Our tasks are moving faster right now because we've received waivers from the federal government that allow us to skip the SNAP interview. And normally we have to interview all SNAP clients and do that full interview before we process those cases. And right now we're able to do it just off paper. So while we are processing 192,000 tasks and those tasks have dropped to 41 minutes per task, that waiver does end this June. And in July, we anticipate that number to increase, the number which is minutes per task. Next slide, please. In legislative session 2017, our division created a new staffing methodology. Prior to this, we simply had math that indicated for a certain number of cases that we had, we received a certain number of staff. We started working into a very complex manner under our new caseload model, now moved to a task-based model, and we track how long it takes for us to do the work that we're doing in the minutes that we're doing them. You'll see in this model, we are averaging almost 30,000 phone calls per month by the eligibility workers. That does not include phone calls by our clerical staff because it's that part of the presentation is to justify the workers that we're using. And those calls are now taking 50 minutes, which has increased significantly since last session. But because of the COVID response, we are doing more of our calls by telephone and more of our work by telephone than face-to-face, which has increased how long it's taking over the telephone. We have seen extreme efficiencies, and we were anticipating to be able to revert positions during this legislative session as we did the last two. But due to the COVID event that we've talked about a lot today, we are seeing an increase in volume in applications and caseload and tasks. Our neon caseload is anticipated to drop, but the other caseloads are anticipated to increase. Our SNAP error rate continues to be under the national average, and we are still processing our cases with 78% of them being processed at first touch. However, first touch is taking longer due to the volume that's coming in and the tasks that are coming in. We are currently processing cases and tasks that double the norm. Our current backlog is as high as 5 times the norm. We normally have anywhere from 2,000 to 10,000 tasks in our queue waiting to be worked. And at this time, that backlog is reaching 50 to 60,000 tasks. Our estimated times to approve and deny cases have increased by almost 30%. The volume is just overwhelming this time. And as you'll see on the slide, that volume translates to a need of additional 226 staff. Next slide, please. Slide 18 is a summary of our major enhancements for this session, and I'd like to take a moment to go through these enhancements and talk about what we're planning to do in our division. Under program access, we plan to use TANF to fund the youth vocational training program to support and mentor low-income students with their future employment goals. We plan to use TANF to support nursing family partnership, which is evidence-based home visiting program to assist first-time low-income mothers and their children. We plan to expand our TANF employment and training services to include a recovery-friendly workplace unit by adding a manager and 9 workforce service representatives who will partner with employers to collaborate on employment being a part of a recovery plan for a person who is suffering from an addiction problem, rather than employment just being the end goal. There is evidence to show that a person who is employed while dealing with their substance abuse addiction, that employment becomes a key component of their support system, and they have a higher chance of recovery. We plan to add 2 social services program specialists to the child care development program. This program just finished their 5-year strategic plan, and 2 additional staff are necessary to meet the goals of the plan. Under program efficiency, we plan to add 2 social services program specialists, 1 to TANF and 1 to SNAP Outreach, the SNAP Outreach is specifically required for federal monitoring and compliance. We plan to add a SmartCom licensing for federally mandated notices. The division is requesting a new child care management system to replace the current antiquated system that has many issues and results in a lot of workarounds, which are time consuming for our staff. The division is requesting to automate and modernize the current Medicaid waiver eligibility manual, which is a manual process. The current process requires physical documentation and written approval by multiple DHHS agencies using inter-office mail, and the mail bounces back and forth. This process takes many weeks to complete while the customers await the outcome. An automated system will be more efficient for our staff and increase efficiencies in customer service. We're requesting to reclass 2 program officers to family services supervisors and 2 administrative assistants to family services specialists to act as lead workers in our energy assistance program. And this reclass aligns with how we staff and supervise our non-employment training program. We are requesting to transfer 1 management analyst and 1 biostatistician to the department's data analytics budget. And under our program administration, the division is requesting to replace our current antiquated inventory system with a modern, more efficient and accurate way to track our more than 4,400 pieces of inventory each year, which we currently track manually. I'd now like to turn the presentation over to my colleague, Mr. Garcia.
Thank you, Deputy Thompson. Good morning, Madam Chair and committee members. For the record, Joe Garcia, Acting Deputy Administrator for the Division of Welfare and Supportive Services. Slide 19 is a summary of our budget reductions. Budget 3228 Administration. We are holding 12 positions vacant in year 1 of the biennium. And this will impact our ability to provide information technology and quality control support to the agency. Budget 3233 Field Services. The impact of permanently closing 4 offices and holding 67 positions vacant for a year will result in the loss of access, reduction in timeliness, reduction of accuracy, and reduction in services to the most needy and vulnerable Nevadans. Next slide, please. Position summary. We are going to have an increase to staffing in budget account 3233, and that is due to the increase in the caseload and the expansion of our employment and training unit. The increase to staffing in budget 3267 is due to the implementation of our child care strategic plan. Next slide, please. One-shot initiatives. Our one-shot initiative is Child Support Replacement System, also known as NB Kids. It's 3 years into the project and remains on schedule and within budget. The user acceptance testing will begin April of 21 and will conclude October of 21. Implementation begins November of 21 with full implementation in May of 22. We're going to run a pilot starting November 21, and then we'll have a two-phase rollout. The first phase starting February of 22, the second phase starting May of 22. Maintenance and operations begins June of 22 and is scheduled to conclude November of 23. Next slide, please. Bill draft requests. This is a list of our 4 bill drafts, which are all policy bills and do not impact our budget. Next slide. Thank you, Joe. Thank you, Madam Chair and Committee, for the opportunity to present our governor's recommended budget this morning. That concludes our presentation, and we're open for any questions you might have.
Thank you very much, Mr. Fisher, and especially your staff that stepped up when Dieter needed help. We had folks struggling and we needed assistance in making sure that they got the services that they needed. So your staff definitely did step up. It's times like this when we realize what these agencies are really there for when folks are truly in need. So we really do appreciate them going through all the work that they did to be able to assist their friends and neighbors get through this process and this pandemic. I did want to just talk a little bit about the customer service that you brought up. It made me curious. I realized the barriers and the hurdles that the employees had to go through and the really great need that was out there from folks who needed assistance. And being able to talk about improved customer service, I think is really important. Can you kind of tell me how that came about? Was working at home? You talked about morale being better. So if you could expand on that, that was more towards the beginning of your comments.
Robert Thompson for the record. In the end of 2019, our division had started the conversations of how to have our staff work from home. And we had actually planned on starting a pilot program that was going to take about 18 months to roll out. When the pandemic hit and we had to crunch together and get this rolling, we found that because of our outreach that had been approved by you, that you gave us the funding to do outreach more than 2 sessions ago, that outreach had the technology to allow our staff to work from anywhere they needed. And actually, what we did, Madam Chairwoman, is I was at work, the pandemic was hitting, and I asked a worker to unplug their computer, unplug their monitor, take it all home and see if it worked. And they linked into their Wi-Fi and it worked. And we ran it through our security team. And in 3 days, we were able to move 75% of our staff at home in what was planned to be an 18-month project. We had some of us that were working some 20-hour days there to get that going, and we did it. And we did it without any break in services. We continued with the timelines that we had previously, and we kept rolling the food stamps and Medicaid out. And our staff were able to be at home with their children. And we took polls of staff, we took volunteers that were able and felt safe to be in the offices, and we took polls of our staff that were over 70, and our staff had children at home. And we're talking about, a very large agency, and we put those models together. And our IT staff, bravo to our IT staff who stepped up and helped us roll that out. And that's the picture of what happened during the pandemic.
I think in addition to that, the key to it, technology, of course, but those staff, when they're working from home, they are connected to our workflow management system. So we know the work that they're doing from home, and it really doesn't matter where they're doing it from. They're connected to our system. We're able to monitor how long it takes tasks to be accomplished. And also our call center technology. Our call center staff can take calls. They can connect to the call center from anywhere. They have an internet connection. So that also provided us with flexibility. So.
Well, thank you. I just want to congratulate you. And it's nice to hear that something we started working on a while back has actually come to fruition, is actually serving people the way we need them to be served. I guess that would lead me to my next question about the closing of some offices. Is the discussion point around that because of the way we've been able to do remote work? And I'm just a little concerned because there are some folks that may not be able to reach out in the same way. So I'm just a little concerned about the closing of the offices. And they all seem to be in Las Vegas.
Yes, Madam Chair, for the record, Steve Fisher, Administrator for the division. All 4 offices are in the Las Vegas area. One of the offices is not a service provided office. It's an office that customers or clients do not go into. It's a processing center. The other 3 offices are what we consider small district offices in the Las Vegas area. Yes, to answer your question, as Mr. Thompson spoke to earlier, we're planning on 30% of our staff working remotely, either on the call center or just working from home. Or again, we could take a look, and we will take a look at our targeted outreach team, where we're placing staff into those non-traditional locations. We could take some of those staff and place them into the locations where these offices are being closed, so that individuals in that particular area who don't have a phone, who don't have access to the internet, can obviously reach our services through our targeted outreach program. So that's obviously an option we'll be taking a look at as well, if these offices are in fact closed.
Okay, and can you tell me which offices, please?
Our Warm Springs office is the processing center that clients do not access, where we just have staff working. The Spring Mountain office, Durango office, and Decatur office. Decatur is at approximately Decatur and 215. Spring Mountain at Spring Mountain and I-15, and Durango near Flamingo.
I'm sorry. So you said Spring Mountain, Durango, and which other one?
Decatur.
Decatur. And where is the Decatur office?
Decatur and 215 in north 215.
That's way out there, isn't it?
It's pretty far out. Yeah.
Yeah, thank you. I appreciate that. We'll have more conversations in the future and look forward to the data that backs up those decisions. So with that, community members, other questions? I think I had Senator Kickover in the queue first.
Hey, Madam Chair, I appreciate it. Mr. Fisher, good to see you again, as always. I had a question about sort of the time frame on some of the position movement within the field services division or office. It looks like you're going to hold open 58 positions for the first year of the biennium as a cost-saving measure, while simultaneously getting authority for additional positions over the course of the biennium. And I'm just curious about how this is going to stack up time-wise. It seems to me that, again, and I'm going back to the arc of economic recovery, we would expect more workload in fiscal year 22 than we potentially would in fiscal year 23, but that it looks like you're going to have more positions in 23 than you will in 22. So how does that play out?
Yeah, these positions, it's all based on caseload and where the caseload numbers fall within the next biennium, determine how many staff we needed in either the first year or the second year. And certainly we have academies that we have to run all new eligibility workers through. We can only have so many staff in each of those academies. So we certainly have to stagger the staff, and it takes about a year for an eligibility worker to come up to speed on eligibility. So therefore, we have to stagger the hiring of those positions, and so that's why it's laid out a little bit differently, with a certain number in the first biennium, and then obviously more in the second biennium, if that makes sense.
Yeah, I haven't seen the actual the hire dates, the anticipated hire dates on some of these positions. I see them as sort of a lump sum, but I mean, is the holding open of the 36 permanent positions and 22 intermittents in the first year, is that purely a cost saving measure, or does that reflect eligibility needs?
The holding of positions open is a cost savings measure.
Okay, thank you. And then in terms of some of the eligibility determinations that we talked about and how much that has grown, I know there's a technology improvement request I think it's in the first year of the biennium for more automated processes for some of the determinations. Is that across all programs, only specific ones? And if you talk a little bit about what technology solutions you do have available for some of the things that you have to look at, like for eligibility, like income and employment, things like that. That would be great.
So I think you're referring to Senator Keycaffer, the request for the replacement to our really the technology initiatives we have in this upcoming biennium would be a request to replace our current child care eligibility system. It's old, antiquated. There's lots of workarounds that our staff have to go through, a lot of manual processes. So we're looking to replace the child care system to obviously improve that program, improve the productivity for the staff that use that eligibility system. We do have another automated process that we're looking at, which is the waiver program. That's currently a very manual process between our three agencies, Aging and Disability Services, the Welfare Division, and DHCFP. Very manual, it takes weeks, things get lost because it's really pushing paper around, if you can believe that. And so we're looking to automate that waiver process. So once again, we can improve efficiency, productivity, and in the end, obviously, get those clients or customers eligible much sooner. Beyond that, I know Mr. Garcia talked about the one-shot for the child support enforcement replacement system. That's another technology initiative. Beyond that, we have implemented a system called Pathos. It's actually an upgrade from our old system. The Pathos is our workload management system. That's the task-based system we were talking about. Whereas work comes into our agency, we create tasks in that system, and then it's almost like a first come, first serve. You know, if you're in a particular office, you just take the next task that's in the queue and you work it, and so on and so forth. So that's a system called Pathos. And let's see, what else do we have? Robert, anything else that, any other systems that you can think of from an eligibility perspective? I know we did put a web-based front end on our old antiquated Nomad system, but this was years ago. It's called AMPS. So it's web-based for our caseworkers, which obviously has helped with productivity there as well.
Robert Thompson, for the record, one of the updates that we have was currently and it's already been in place is Pathos has been re-imaged to the current system. So while we speak about Pathos repeatedly, that's actually called Current now, but it's doing the same technology that it was before. It's our task-based management system that created the efficiencies to the task-based model from the caseload model.
Okay, yeah, I appreciate that. And I think, Madam Chair, the second question I had was related to the pilot program with the Department of Corrections and getting into our institutions for eligibility determinations so that inmates have program eligibility, particularly for Medicaid upon release, which I believe they're entitled to. It looked like it was listed under your accomplishments. Is that something that's going to be continued in the upcoming biennium?
I'm going to ask Mr. Garcia to talk about that one. He's heading up that project. This is Joe Garcia, for the record. Yes, that is going to continue. I will tell you that we've been experiencing some difficulties, but mostly due to COVID, causing lockdowns at the prisons. And so we can't get staff in there. However, we have come up with alternatives to collect those applications via electronically through email and or fax. We are also working with the Warm Springs Correctional Center up here in the north. Just recently, we approved a 4-page, it's double-sided, application for COVID inmates. So we are doing that. And we are also working with the correctional centers, Washoe Correctional Center and Clark County Correctional Center. We've had staff there. We just put staff actually back at the Clark County Correctional Center. We are in the works with North Las Vegas Jail to collect applications there. They are very enthusiastic about working with us, and so are we. We are still moving forward with Department of Corrections, back to Department of Corrections, and working and getting, we've already had our targeted outreach staff at some of those facilities, but due to COVID, we pulled them out. We're still collecting applications from them, but not as many as we'd like. So certainly as we move forward, we are going to hopefully continue to get more applications. We did also work on a report that is going to improve a difference in numbers that we were seeing that were reported from Department of Corrections and the Division of Welfare and Supportive Services. So we're to say that we are working to move forward and getting additional applications, getting as many people on what we call suspended Medicaid. That is the program that we are, is what it's called, to get them on before they leave the facility so they can walk out with their actual Medicaid card in hand.
Thank you very much for the update. I appreciate it. Thank you, Madam Chair.
Go. Thank you, Senator Kickover. Appreciate that. I believe I have a couple of questions from Assemblywoman Tolles. Is that
Madam Chair, this is Speaker Frierson. Can I just ask,
sure.
Because it was Senator Kickover's question that sparked something and I don't want to get off the topic.
Sure, go ahead.
Thank you for your indulgence, Madam Chair. Are you saying that I was under the impression that there are some states that have advanced legislation to make it easier for inmates to apply for and be ready to receive those benefits upon release. That may be dealing specifically with Clark County Detention Center and local county detention centers and not necessarily state prisons. But are you saying that you do not need any statutory adjustments to be able to accommodate having folks eligible before release?
So Joe Garcia for the record. So what we're doing, suspended Medicaid is exactly that. So let me explain what that is. We can go in and we can have inmates apply before they are released. We approve that application, but when we say approve a suspended Medicaid, we're approving benefits that they are suspended because technically or due to regulations, they cannot be eligible for Medicaid while they're in the facility. So we put them on a suspense. When we are notified from the facility that they have been released, we just flip a flag and their benefits are released. But as soon as we approve that suspended Medicaid application, they are issued a card. And so the card will go to the facility. It'll be in their properties. So when they are released, the day they're released, it's in their property and it's handed to them. So they're not actually getting Medicaid while they're in the facility. It's suspended. And as soon as they're out, we flip the flag and they're eligible actually for that day and for the entire month, whatever that day happens to fall on. If I could, Madam Chair, I could just add on to that. Certainly, if there was a way to pass some sort of regulation where Medicaid eligibility would be allowed in the prison, for example. Certainly, I know Joe says just flipping a flag, but it is a lot of extra work for our staff to just flip the flag when we unsuspend them, for lack of a better term. If we could just make them eligible while they're in the detention center or in prison, certainly that would simplify our eligibility process for sure. Anyway, I just thought I would add that piece of extra information to that. Thank you.
Thank you. I'm under the impression that not necessarily regulatory, but again, there's other states that have made some statutory adjustments to make that transition seamless. Because once, down here in Las Vegas, they just let them out in the back alley in the middle of the night. And once they're out, it's really difficult to ever catch them again. Well, when I say catch them, I mean get in contact with them. And so I was under the impression that other states have advanced legislation to make that seamless transition so that and I'm not 100% sure they're either immediately ready or can start getting some type within 30 days of their release services, particularly if it's related to mental health and drug treatment. So I will certainly be following up with you all to get some clarity on that.
Thank you, Speaker. Assemblywoman Tolles, did you have a question?
Yes, thank you, Madam Chair, and God bless all of you. That's just hearing the caseload certainly tells a stark story of what's happening in our state. And appreciate the burden that you have and how you've managed to keep up and while transitioning your employees to safely work. Just commend you for all of that. I had a couple questions that actually Senator Kekeffer really touched on a lot of them, but maybe I could just follow up to clarify. One is, if I have it down correctly, the 226 new full-time employees. I had similar questions in terms of the arc of the timeline of that, as well as the arc of hopeful economic recovery. So along those lines, are those 226 full-time equivalent positions, are they meant to be permanent? So in other words, if we do see a reduction in the caseload as we see the economy reopen more, as we see less people needing these services, what happens then to those 226 positions?
Thank you for the question. How many are in the room?
226. How many?
They're all women?
No, they're all permanent.
So the 226 staff we do have some intermittent staff on our roles today, but the 226 staff that we're asking for are permanent. Certainly, as Mr. Thompson spoke to, we have backlog of about 50,000 tasks now, so we're certainly way behind, and certainly it's really the caseload projections that drive our staffing methodology. So we rely heavily on what those projections look like, how many tasks do we project we're going to have in the future, which really determines how many staff we need. And so certainly I can and will get with our data analytics team and work with them and find out, what exactly is in those projections into the future. And we can certainly share that information with you if you would like.
Yes, thank you. I would appreciate that. And then my next question is, I'm intrigued by your statement that we have a waiver for the interviews and that's helped to reduce the time spent with each client. I assume, first of all, that waiver is federal, that's controlled at the federal level, so we control. So maybe first, just if you can confirm that. But then second, is there anything that we lose when we don't perform that interview in terms of just a confirmation of certain requirements, or is it something that we've been able to recapture through other means like electronic sharing of documentation and so forth? How can we keep that efficiency without losing some of the benefit of what you gain from those interview processes?
Robert Thompson for the record. The waiver, it was a federal waiver, yes. The federal waiver came from the USDA Food and Nutrition Services. I've been doing this for 25 years. I've never seen a waiver like this come through. It was done specifically because of the COVID event. There were concerns at a federal level and at a state level that when you are not doing an in-depth interview with each customer, you may miss eligibility requirements that could cause a loss of accuracy. Keeping in mind that Medicaid is the same households and have income and asset requirements, and Medicaid is not required an interview for years. The division does integrated interviews. We do the food stamp, Medicaid, integrated processes. We do the food stamp, Medicaid, and TANF interviews all at the same time. Not all states do that, but we are integrated. So with Medicaid and food stamps, we have electronic interfaces. We check the unemployment records, the child support records, the social security records, the new hire records, and we are able to get in electronically and go through the process for every application to the best of our ability to make sure that our eligibility determinations are accurate. If that answers your question.
For that. Yes, thank you for that. So it sounds like I really appreciate that, because of course the concern is we would want to make sure that the accuracy and but if we are able to continue to accomplish that without the in-depth interview, perhaps it's something worth elevating up to the federal level to say we can keep this efficiency and therefore reduce your workload while still maintaining accuracy. Something just from an efficiency perspective to consider. It sounds like you have, and so thanks for answering that question.
All righty. So with that, committee members, I have not had anyone else reach out to me through chat or other means. So is there anyone else that has any particular questions at this time? I'm not hearing anyone. I do have one final question that was not addressed through all this. Under your new programs, I see that the governor is recommending a block grant for a new youth vocational training program for low-income youth. I was just wondering what that looks like in generalities. I know we have other programs out there already existing, and I know through Owen and other agencies that they're doing some youth training. So I was just wondering what this particular program, your thought process was.
So, Madam Chair, for the record, this is Steve Fisher. But we wanted to utilize TANF dollars to assist or provide additional funding to an existing youth training program. So we will put out onto the streets an RFA, for example, and request those programs to apply for the funding, TANF dollars, to then obviously improve their current program. This isn't the creation of a new youth training, vocational youth training program at all. We just wanted to utilize TANF dollars in support of an existing youth vocational training program. Hope that answers your question.
I think it does. Thank you very much. Where did we get this $1.2 million from? We don't have extra money in TANF, so where are we moving it from to do this? What are we not going to be doing in the future?
So we are projected to have at the end of the biennium a $31 million grant left at the end of the biennium. And so currently our caseload is projected to go down by 6.27%, I believe, if my memory serves me correct. So we are able to take that, I think it's $600,000 per year, and utilize those dollars for this vocational program.
So we're going to have reserves, but we're not going to increase benefits or give a little more assistance to those families that are in need. We're So that wasn't part of the discussion and giving a little more support to some of the families, because I know TANF benefits are fairly low.
Well, one of the deciding factors was we had that $20 million penalty looming over our heads, and until such time, we actually received, notification that those penalties are waived. We were hanging on to some of those TANF reserves just in case they actually went through and penalized us for $20 million.
Okay, thank you. This is very interesting. I look forward to the conversation when we get to the subcommittee level about all the pieces of this puzzle that need to fit together, because, we have had a lot of discussions over the years about TANF and the needs and the level that we support families that are in this position. So I look forward to the future conversation on this. That would be great. Any other questions from any other committee members? Well, I'm not hearing any, and I'm not seeing anyone reach out. So thank you very much, Mr. Fisher, again, and especially, your leadership and your staff and everything that they've done through the pandemic. The state really appreciates all their hard work. So thank you very much for everything that they've done. So with that, committee members, I think that brings us, we're actually a little bit ahead of schedule, which is great, and had really good conversations on these important issues. So it's just a bit past 11:30. I was just going to do a 30-minute break, but I think we'll do 45 since we're a little ahead of schedule. So if everyone would please tune back in at about 12:15, that would be very helpful. And we'll proceed on to public and behavioral health, where I know we're going to have a lot of conversation. So everyone, take a break. Take a walk, get out of your chair, and I'll see you at 12:15. Thanks. We're in recess.
Chair, we are unmuted and you can begin when ready.
Thank you very much. I'll go ahead and call the meeting back to order. Thank you, committee, for getting back so quickly. I appreciate it. Next on our agenda is the Division of Public and Behavioral Health. And I believe we have the administrator with us. So if we would go ahead and cue them up, please, and we can go ahead and proceed with their presentation. And we'll do questions at the end as we've been doing throughout the day.
I think you should hit later. Chair, we are unmuted and you can begin when ready.
Thank you very much. I'll go ahead and call the meeting back to order. Thank you, committee, for getting back so quickly. I appreciate it. Next on our
Okay, good afternoon. I apologize for that. My name is Lisa Sherrick, Administrator for the Division of Public and Behavioral Health. Here with me today is Debbie Reynolds, Deputy Administrator for Community Services, Administrative Services, Julia Peak, Deputy Administrator for Community Services, Margot Chappell, Deputy Administrator for Regulatory and Planning, and Joe Millay, Deputy Administrator for Clinical Services. I also have with me Dr. Stephanie Woodard, Senior Advisor for Behavioral Health, and Dr. Elizabeth Neighbors, Forensic Director. Moving to slide 2, this provides an overview of our division's vision and mission. Slide 3 provides an overview of our division's organizational chart. Slide 4 provides an overview of our agency's operations. We are comprised of 5 service branches: community health, regulatory and planning, clinical, behavioral health policy, and administrative services. Slide 5 through 9 provide an overview of our division's accomplishments. Noted on slide 5, Forensic Services has successfully completed all requirements specified in the Burnside Consent Decree without penalties for further monitoring. We also received gold standard certification for Nevada's Central Cancer Registry call for data for the 2019 data submission. Noted on slide 6, our division-led collaboration across multi-jurisdictions and agencies to coordinate resources across all disciplines related to the COVID-19 pandemic. Moving to slide 8, DBPH developed a multidisciplinary strike teams that continue to work together on strategies to prevent the spread of COVID-19 within Nevada's licensed facilities. While I wish I could say Nevada facilities have had 0 deaths, compared to the national average of the percentage of deaths in facilities as it compares to total deaths, Nevada has consistently been under 25%, whereas the approximate national average is 40%, with some states as high as 80%. Additionally, Nevada has been under 20% since August, and as of January 19th, we are at 17.3%. Moving to slide 9, lastly, we accomplished standing up the Nevada Resilience Project that focuses on disaster, behavioral health prevention, intervention, and referrals. Slide 10 provides a summary of agency updates, which include continuing vital mobile outreach safety teams across Nevada and maximizing resources to ensure our programs provide quality services and care. I would like to note there are no major enhancements in the FY 22-23 HIV program. That includes the Nevada Medication Assistance Program, or NMAP. However, in response to Assemblyman Frierson and other members I heard have concerns, DBPH has not implemented any changes at this time. While we did plan to roll out a new policy effective January 18th, 2021, we are continuing to postpone any changes to the program to allow additional time to review the impact of community partners using the 340B program, the program income received by them, and the impact of rebate revenue received at the state level. Slide 11 provides an overview of our division's priorities. This includes continuing to provide evidence-based forensic services and keeping up with capacity needs of Nevada. Continuing to improve health services using a population-based approach to address community health needs, minority health, and disparities to promote healthy people in vibrant communities, and implementing measures to prevent and control the spread of infectious diseases, including COVID-19 in licensed facilities. Slide 12 provides a snapshot of the division's requested funding for FY 22-23. Slide 13 provides an overview of projected caseload for clinical services. You will note projected demand for behavioral health services at the end of FY 23 begins to increase after an initial decrease during the early months of the pandemic. However, the overall average projection demonstrates a decline. Staffing coverage remains challenging due to the pandemic, and there are multiple position vacancies, but recruitment efforts continue. Slide 14 provides an overview of our average facility populations. Northern Nevada Adult Mental Health Services and Southern Nevada Adult Mental Health Services numbers include the average annual census of individuals served. Forensic inpatient includes the average annual census of individuals served, including restoration and long-term commitments. Forensic outpatient for Lakes Crossing Center includes restoration clients and pre-commitment clients for the year, while forensic outpatient services for Stein only includes restoration clients for the year. Slide 15 provides our FY22, FY23 biennium budget account summary. And beginning on slide 16, we've outlined our major budget enhancements for community health services. We are requesting to establish a fee of not more than 8% for the registration and renewal application of a radiation machine, mammography machine, healthcare facility, and medical laboratory to support the cancer registry. In chronic disease, we are requesting continued funding to fill a gap left by federal restrictions to provide breast cancer screening and diagnostic services to women aged 40 to 49. We are also proposing alternate funding for the oral health program. DBPH has developed a strategy to diversify funding from radioactive material license fees to other grants and programs to reflect a more appropriate cost allocation. Additionally, we are requesting funding for the Early Hearing Detection and Intervention System, or EHDI. EHDI data is currently entered into the Vital Records System, or VRS. The Office of Vital Records is intended to replace the current VRS, and EHDI functionality will not be included, which creates the need for a new system to manage Nevada's EHDI clients. Finally, we are requesting a transfer of temporary assistance for needy families, or TANF funds, from the Division of Welfare and Supportive Services to support the Home Visiting Nurse Family Partnership Program. Slide 17 outlines major enhancements for regulatory and planning services. We are requesting to upgrade the Vital Records system. The Office of Vital Records is mandated per NRS and NAC 440 to register birth and death records, issue birth and death certificates, and to complete amendments for paternities, adoptions, errors, and gender changes. The current system is outdated, difficult to use, and is difficult to modify mandated legal changes. Additionally, we are requesting to eliminate 3 vacant FTEs in the Environmental Health Services section to meet revenue projections. We are also requesting 4 new positions in the Bureau of Healthcare Quality and Compliance to support an infection control and prevention unit in order to proactively conduct infection control assessments within the approximate 766 licensed residential and long-term healthcare facilities. We recognize during the COVID-19 pandemic, there was a gap in the approach the division was taking to prevent and control infections, and quickly realized this unit is needed to specifically address infection control and prevention in facilities where Nevada's most vulnerable citizens reside, and foresee this need continuing in the ongoing future. Slide 18 outlines major enhancements for clinical services. We are requesting funds to upgrade and maintain security cameras throughout the SNAMS campus for the safety of clients, staff, and the public. We are also requesting funding for a new unit dose packager, which converts bulk medication into unit dose dispensing packaging at a significant reduction in medication cost. Additionally, we are requesting to transfer one senior physician from NAMS to the Division of Healthcare Financing and Policy to enhance Medicaid reimbursement related to pharmacy services. Slide 19 outlines major enhancements for administrative services. And I apologize, there appears to be a lag, so I just wanted to point that out. We are requesting a cost allocation redistribution to remove general fund in the administrative accounts and fund the full cost allocation into the behavioral health accounts. For transparency, general fund will be removed from the administrative accounts and budgeted in the behavioral health accounts and then transferred to the administrative accounts through cost allocation. This slide also outlines our major position transfers. We are not covering all position transfers, but want to highlight that we are merging all data analytics into one budget account for department-wide standardization. For DBPH, this involves 17 FTEs. Slide 20 outlines our proposed budget reductions for clinical services. We are requesting to eliminate SNAM satellite office space and associated operating costs at 3811 West Charleston. We are also requesting to maintain 5 FTEs vacant at SNAMS through fiscal year 22 with reinstatement in fiscal year 23. Slide 21 continues our proposed budget reductions for clinical services and behavioral health wellness prevention and treatment. We are requesting to maintain 22.55 FTEs that are currently vacant at NAMS through fiscal year 22 with reinstatement in fiscal year 23. Additionally, we've requested to reduce community-based living arrangement services or CBLAs through fiscal year 22. This reduction does not displace any current clients receiving these services, but may result in delays for new clients. We are also requesting to reduce problem gambling services. Slide 22 outlines proposed reductions for regulatory and planning services and community health services. We are requesting to align general fund revenue for CBLA inspections and associated indirect based on actual need. We are also requesting to maintain 3 FTEs vacant in community health nursing through fiscal year 22 with reinstatement in fiscal year 23. Moving to slide 23, continues proposed budget reductions to rural clinics. We are requesting to maintain 11.26 FTEs vacant through fiscal year 22 with reinstatement in fiscal year 23. We are also requesting to align revenue from general fund to other sources and reduce psychiatric services to individuals with mental illness, including peer support services. With these reductions, referral to community-based services will increase and wait lists may be generated. This will affect medication clinics more than other services. We will continue to support medication clinic with nursing and psychiatry. However, clients may not have additional support from some therapies and counseling referrals. Slide 24 summarizes our requested positions over the biennium. Slide 25 outlines our requested budget BDR for the cancer registry. And with that, happy to answer any questions the committee may have.
Thank you very much. I do believe there were some questions. Speaker Frierson, did you want to ask your question, I believe, on this particular item?
Madam Chair, if I can have a moment to gather myself, I was running a little bit late.
Oh, no, that's fine. I'll go ahead and go to Dr. Titus next.
Thank you, Madam Chair. I appreciate it. Thank you, Madam Chair. I have a question regarding the revenue source and position for the Nevada Central Cancer Registry. We know I've had this discussion, and I think this committee has had this discussion on how to pay for that as opposed to providers and those kind of things. We were afraid we were losing information and not getting all the data. Someone like myself who took off a basal cell cancer in somebody didn't want to report that because that was going to cost me so much money if I reported a basal cell, et cetera. So to gather the data, which is really important that we have, I understand that we're changing the funding cost, but I see in there that you're going to pick up 2 positions along the line with that. And would that be to assist providers to file their data? Because that was one of the issues and one of the roadblocks to the information was not having the providers, or it was a little bit difficult to actually load the information. Is that what those 2 providers are going to be doing, or 2 health program specialist positions?
Dr. Titus, this is Julie. I hope you can hear me okay. Is that volume okay? Okay. So these are thank you so much. So these are the positions that you all had graciously provided some general fund to support. So it's going to continue to do exactly what you just said, specifically help providers that are non-hospital, so don't have certified tumor registers already on staff that have the level of expertise needed. It's going to help all the other entities pretty much get their cancer data reported. The proposal you have in front of you is a known fee, and I'll just say we did our best to make it the smallest fee spread across all the entities who could potentially be reporting. It's anywhere from $10 per year to up to $500 per year, but it is based on the amount you currently provide, and it will help even the larger hospitals if we're doing quality improvement to the dermatologists who are just trying to remove cancer in their office and don't have a formal reporting system. It'll support the whole scope on behalf of the registry.
And then, thank you for that. And then I have a question regarding the Women's Health Connection and some of the infectious disease registry and where we're going with that. We've heard testimony in our last session about the, and I haven't heard it today in responding to a budget item regarding syphilis, neonatal syphilis, intrauterine syphilis, all those concerns that I have. And we have the highest rate of newborn syphilis. I think it's still in the nation. And I'm wondering, is that, will we see that later on and what we have maybe figured out how we're going to pay for that? I'm not seeing it in any of these budgets yet. Is that on somebody's plate so far?
So I'll say, as we've looked at COVID and had to redirect resources in our EPI programs, we know that syphilis is just going to get worse in the nation, not just Nevada, but Nevada does have, as you mentioned, the highest rates of syphilis, second highest rates of congenital syphilis in the state. We are going to be working with our STD program. We've reached out to our federal partners as well to see if we can get support from them, not only in additional funding, but in direct technical assistance support. We did not ask for general fund in this scenario. We did present some options at In-Room Health, talking about perhaps additional screening in ERs and other opportunities where we feel these women are being missed and we can intervene more appropriately. But at this point, it will be our STD programs primarily, and then partnership with the private sector to screen them. I'll also note that we've done a ton working with Medicaid, and probably Candace McDaniel, who's here with me, has been doing a phenomenal job in addition to overseeing the vaccination efforts to work with Medicaid and partners across the state to develop a congenital syphilis plan. What we're doing right now is just figuring out what we can afford in the different programs to support those. But it's a really nice integrated report looking at how we could address it based on the resources that we have. Happy to provide that to the committee as well. We didn't, but happy to provide that.
Great, thank you for that. Because one of the things that I think the world is obviously focused on the pandemic and for COVID, but we can't forget the disease such as congenital syphilis that still haunt us and actually raise our costs when we're looking at Medicaid. 60% of births, is that what we heard earlier, are actually through, paid for by Medicaid now. When we're looking at those kind of monies, we need to be able to work across all these different departments and make sure that one department didn't eliminate a service, that the other department is now going to have to pick up the cost of that decision. And these healthcare budgets really are intertwined. And so I just want to make sure, and I'm looking forward to some of that, the data and some of what the other committees have done, but making sure that we're kind of working together to merge these budgets that really play off of each other. And by cutting back on one source, we're now causing an increase in budget on the other source. So thank you for that. Looking forward to more of your information. Thank you, Madam Chair.
You're welcome, Doctor. I believe Senator Ratty had a question next.
Sorry, I was struggling there a little bit with my.
We all are. That's okay.
So I'm just curious in terms of the thinking with behavioral health, sort of broader picture, and I know it's a challenging budget, and I know you've all been asked to make cuts. But I think from everything that I'm reading that we're concerned about a lag with behavioral health issues really presenting as the pandemic is winding down, the trauma of the pandemic will start to be building and the need for resources will be more significant. And so I'm just wondering about how you're wrestling with that in terms of what you're recommending to continue doing versus what you're recommending to cut.
Go ahead, Debbie.
You want me to address
Yeah.
this? Okay. So Stephanie Woodard for the record. Senator Ratty, you're exactly correct. We anticipate based on previous experience nationally and internationally with other disasters that the expected behavioral health surge is expected between 12 and 18 months following the index event. We know that many people have been able to really hold on related to coping and managing with stressors secondary to COVID up until this time, but we have seen an escalation in need. In anticipation for that, we're really looking at how we can draw in additional federal funds and have been able to maximize as many federal funds as possible to help to offset some of that. In addition, we have, and Dr. Titus had conveyed that really healthcare system and the behavioral health system is very complex. And so what's occurring in one budget may or may not have an impact in others. And while there is planned proposed reductions in behavioral health services related to clinical services and DPBH, we do see that the private sector has been able to expand and absorb some of the need, including our certified community behavioral health clinics.
Great, thank you for that. And then just a little bit more specifically, could you just put a little bit more color on the CBLA cuts? I heard not displaced, but is it no new additional spots or is it a smaller number of spots than we would have hoped to have had? What does that look like?
Lisa Sherrick for the record. So we anticipate that this will reduce the number of spots or availability for funding for folks. You are correct. Right now, it doesn't affect anyone where they would be displaced, but it definitely could impact future needs that people may have. So I don't have a specific number, Senator Ratty, only because typically, it's based on that individual's need and what tier that they would fall in for the CBLA funding.
Thank you. I appreciate it. Thank you, Madam Chair, for the opportunity.
Thank you, Senator. And questions from anyone else? I have not seen anyone reach out. So are there any other questions at this time?
Madam Chair, I'm regathered. If I can revisit a question I had earlier.
Sure, Mr. Speaker, go for it.
Thank you. And I had raised earlier with Director Whitley a question about 340B providers that he indicated would be addressed later. So I just wanted to follow up on that, particularly because we're talking about budgets, and I know that there's a concern about the impact that budget cuts may have on HIV patients and the 340B providers' ability to continue providing that service in the manner that I think those patients are accustomed to without disruption. So could you follow up on that, and to the extent that, and I think Director Whitley touched on it, that nothing has changed, but there is a new model. I'd like to make sure that I get some clarity on that.
Hi, Lisa Sherrick for the record. I We'd just like to start to say there's no major enhancements in the FY 22-23 HIV program. That includes the Nevada Medicaid Assistance Program. We have not implemented any changes at this time. We did plan to roll out a policy change January 18th, but that has continued to be put on hold. That has been communicated to the providers. And this will allow us additional time to review the impact of the community partners using the 340B program, the program income received by them, and then the impact of rebate revenue received at the state level. So just to reiterate, we have not implemented that change. I apologize if there's misunderstanding in the community about that, but happy to answer any other questions you may have related.
Thank you. And I think that obviously I'm relying on information that was circulated about the intended implementation of January 18th. So thank you for that clarification on that. I'll just pass on since we're here. The concern, I think the main driving concern was as you consider it, and in particular, the impact that any cuts might have on patients and providers, that I think it certainly has not felt like from the correspondence that we've been getting that patients have felt like their voices have been as sought out, I want to say. I don't think that anybody would reject them expressing themselves, but to the extent that it's helpful, that's the nature of some of the communications that we've been getting.
And Lisa Sherrick, for the record, I appreciate receiving that feedback. Certainly more than happy to have any conversations with people. We don't want people to feel that they don't have a voice, which is also why we have looked at really drilling into this further and postponing it, but happy to receive any emails or phone calls directly if anyone has any specific concerns or the clients themselves. So I can help remedy any of that.
Thank you very much. I appreciate it.
Push that button. Thank you, Speaker. Senator Dondero Loop, you had a question?
Yes, in reference to your budget reductions, I noticed that, and the slide sort of slipped by it, that problem gambling services were decreased. Can you talk a little bit about that?
Thank you for the question.
How that was, I'm sorry, I thought of one more thing before I stopped. Maybe how that was decided and moving forward, what's going to happen. I'm sorry.
Thank you for that question. For the record, really when it came down to the reductions for our division, we were wanting to try to do the least amount of harm across the division. And we have worked collaboratively with the program to identify an amount that the program could withstand without having severe consequences. I do recognize any cut is a concern for any program, but with those conversations had, it seemed that this was an amount that the program could work within and still deliver services.
So am I clear that there will be some services, it'll just be a reduction? Is that what you're saying?
Lisa Sherrick, for the record, correct. Yes, there still will be services, but just at a reduced capacity.
Okay, thank you kindly for all your work.
And along that line, so since we're in the general fund reductions area, I just wanted to have a brief conversation about the reductions to NAMS, SNAMS, and then the rural clinics. We know where we've been with mental health in the past in this state, and we don't ever want to go back there again. We've made a lot of progress, and right now in the state, I believe mental health is top of the list of folks' concerns. So I just wanted to have a short conversation, and we'll dig in more in the subcommittee about these positions that are going to be held vacant and what the impact might be to services to the patients that would need these services.
I'm going to turn that question over to Joe Millay, Deputy over Clinical Services, that can provide some more details.
Thank you.
Good afternoon. Hi, good afternoon, Joe Millay for the record. Thank you, Madam Chair. And those reductions to NAMS in particular, those were probably the largest vacancy we've had. That continues to be a challenge in the Northern Hospital, both the inpatient and outpatient settings. The applications to fill those positions have been very limited. And so that, although we continue to recruit and try to hire, it still remains challenging. So what will occur is that the possibility of overtime will increase, the use of agency, all of those things may increase over time as we try to fill that void and provide those services. So luckily our wait list in the NAMS inpatient facility has been stabilized. And so we've been able to manage those services and reduce that wait list still. Our outpatient services are stabilized as well. They have decreased that caseload over the last couple of years. We've been working hard to get those clients insured and on to other resources in the community. So we will continue those efforts in order to get those people into the right services so we can serve others that do not have insurance. Now, overall, with those vacancies, there will be a possibility that the wait list may increase over time. It could be that they have, we'll just have to look at that as we move forward in that. But so far we've been able to manage it pretty well. And so I'm hoping that that continues to do so.
Thank you. And when I look at the classifications of psychiatric nurse, licensed psychologist, are those contracted positions or are those state positions?
The ones that are vacant are all state FTEs.
They're all FTEs. I just want to make so let's just get down to brass tacks. So is it the fact that they can work for someplace else for more? Are we competing with other places?
We try our best to be competitive. We do have a good benefit package for the state, but the actually hourly rate is not comparable to other private sector.
Okay, thank you. We appreciate that. Committee members, are there anyone else have any other?
Madam Chairwoman?
Yes, go ahead.
Thank you so much. So my question is just on specific to public health and the balance forwards in each year's 14 million in 22 and then 11 plus million in 23. I imagine that some of that is grant dollars, but it still seems to be like a large chunk of money to be balancing forward. So when we go into the more specific details on pre-session hearing, I'll just be interested to know if all of that is kind of because of grants and grant requirements for spending different years versus what is obligated and what is it?
Thank you, Debbie Reynolds, for the record, Deputy Administrator over Administrative Services. Our balance forwards are typically fee reserves. We don't balance forward federal funds. And so we're happy to address any additional questions and provide you with further information as we get into committee meetings.
I appreciate that. So get grants out of my head. It's all fee reserves that you're, okay. We're required.
Okay, thank you. Other committee members, other questions? Seeing none, I have one final quick question. So the expansion of the home visiting nurse program, which I thoroughly support. I think it's great that we're doing this. But the use of TANF dollars to do it, I was just wondering about that. And the fact that you're looking at an additional 100 families. How many families are we serving now? And what is the actual need out there? How far does that 100 go to addressing the need?
Julia Peak for the record. We're pulling the number we currently serve now. Happy to provide that to the committee. This program, as you know, is hugely successful in helping parents to be and new parents. The 100 that we've identified in Clark County and Nye County are easily served. It's just ramping up the program already in that county. We're also looking at building in additional support for families that have substance abuse issues, as well as we've noted this in our congenital syphilis program as well as target population. So I'm happy to provide the number we're currently serving and that growth. And then if you need more information on our partnership with TANF, they too have been working with us in the interim to look at maternal and child health across the division and the department, and identified this funding stream as one that would help the families that are most needy and who are expecting in our state.
Okay, thank you. And so is this funding stream part of the reserves that they were talking about earlier?
Lisa Sherrick for the record, no.
So this is a separate funding stream not coming from the reserves?
Debbie Reynolds for the record. Yes, it's a transfer from the Division of Welfare.
Okay, thank you. So that clarifies that. So we just need to backtrack that to see where that's originally coming from. Thank you very much. Okay. Committee members, any other questions on this particular item? I'm not hearing anyone. Well, thank you all very much for all of your hard work, and we look forward to seeing you in Carson City. Thank you. So with that, I believe we can move on to the Division of Child and Family Services. And we'll have Mr. Armstrong, the administrator, presenting. Oh, excuse me, presenting today.
Good morning. Yes, let me get my screen shared. And we will begin. Yes, my name is Ross Armstrong. I'm the administrator for the Division of Child and Family Services. I look forward to going over this overview today and then continued conversations throughout the rest of the legislative session. With me are my deputy administrators, including Susie Miller, who is our deputy over residential services, Alexis Tusi, who is over our community services, Dr. Catherine Roos, our deputy over quality and oversight, and Mandy Davis, our administrative and victim services deputy. On slide 2, you can see the Division of Child and Family Services vision and mission. The vision being safe, healthy, and thriving kids in every Nevada community. For us, every Nevada community is not just geography. We also talk about making sure that we have safe, healthy, and thriving kids in communities of color, the LGBTQ community, our tribal communities. Anyway, there may be a population that we need to focus on. That's what we talk about when we talk about every Nevada community. That vision has been helpful to us during the COVID-19 response. In particular, for us, that order is important. We have to have safety before we can focus on health, and then health before we can focus on thriving. And as we've had to work to protect our capacity to serve families during the crisis, it's provided some clarity in the priorities for us. On slide 3, you can see our organizational chart. The Division of Child and Family Services touches 4 major systems in the state of Nevada: the child welfare system, the juvenile justice system, children's mental health, and victim services. Our deputies are organized so that their functions align. So residential services is any facility that we are operating where we have children staying in a 24-hour setting. Community services is really about helping connect families to services in their communities and helping them thrive in that way. Quality and oversight. Our programs have varying levels of federal requirements, state NRS requirements, and so quality and oversight really looks towards that compliance piece, policy development, planning, and continuous quality improvement. And then in administrative services is our information services, incredibly important to continue to our operations, as well as our fiscal services. In addition, the Division of Child and Family Services is the point agency on victims of crime services. And so that is also under our administrative services team. Slide 4, we talk about the summary of agency operations. Essentially, what I just discussed in more detail with the budget accounts in terms of all of those teams that we have. When we think about the community services in particular, that's our rural child welfare. Nevada, for those of you that may not be as familiar with our child welfare system, we have a very unique system where we have some state oversight and collaboration at DCFS, and then we also provide child welfare services out in our rural communities where Washoe and Clark have their own independent agencies to operate those. Again, our agency operations for quality and oversight and victim and administrative services are on page 5. Some accomplishments aside from the just making it through the COVID-19 pandemic. And for us, that was really, a two-pronged approach of making sure that we were slowing down the spread among our staff and the families we serve, but then also protecting agency capacity, working hard to make sure that we didn't have outbreaks that would terminate our ability to provide services throughout the state. Aside from those COVID-19 challenges, during the interim, we were able to work with Medicaid to get the approval of a 1915I state plan for those youth in specialized foster care, which is a tremendous step forward in protecting and securing the health of that special population. Last session, the legislature approved the conversion of 3 of our mental health facilities to formal psychiatric residential treatment facilities. This has helped us fiscally increase our ability to bill and pull down that federal Medicaid funding for the services provided and increased the quality of care. For youth, that was quite a process that included getting accredited, CARF accreditation and licensure through the Bureau of Healthcare Quality and Compliance. Also approved last session was a 12-bed residential treatment center expansion at Desert Willow and a slight reduction in juvenile justice beds. The idea that there were youth in our juvenile justice correctional beds who needed more formal mental health treatment rather than correctional care. And that residential treatment center unit has now been opened and is serving youth. And victim services. The 1 October shooting really made it clear for us in the state of Nevada that because we at the Division of Child and Family Services have housed the Victims of Crime Assistance Program, that in the eyes of the Federal Department of Justice, we are the Victim Services Agency. And so we received special grant funding to respond to that shooting. That grant funding lasts for a couple more years. In addition, the governor last session proposed a bill to take the Victims of Crime Compensation Program from the Department of Administration and transfer it over to the Division of Child and Family Services, allowing us to have victim services strategically placed under one roof. And so that transfer occurred during the last interim as well, which included the adoption of a new state plan for victim services outlining the qualifications for that program. Some key agency updates, as has been discussed before, there's a request to transfer our data positions to a consolidated budget in the director's office. Just some examples. They already work well as a team together, and so just some examples of the benefits of that. We were able during the COVID-19 pandemic to quickly identify and confirm an absolute collapse of reports of child abuse and neglect, and the Office of Analytics helped us to pinpoint that the source of that collapse was from educational professionals. And so we were able to shift some federal funding around and to strategically go after other reporters who could help us while children weren't in school. That was a big help from the Office of Analytics. They're currently working on a publicly facing dashboard for us to have an always up-to-date sense of the children that are being served in out-of-state facilities and in-state facilities so that we can quickly identify trends and inform decision-making processes. During the interim, the Committee of Child Welfare and Juvenile Justice considered some proposals that I anticipate the money committees will hear about during the session. One proposes legislation to allow for the reinvestment of adoption savings to comply with federal requirements. And another is a reinvestment of juvenile justice savings to the County Community Corrections Block Grant, which really we're hopeful will potentially start the engine of prevention investment in the state of Nevada. So that committee has those two proposals, and we're happy to provide information during that process. Two other exciting projects during the interim include AB 150 from the last session, which takes a look at what's called the Federal Extended Foster Care Program. We currently have a continuing jurisdiction program, which is completely state funded or county general fund funded. And there's a federal program that we can access. And so we anticipate the interim committee also proposing a bill that would allow us to access those federal funds for those transition age youth. We've had some great successes, including working with the Nevada System of Higher Education on tuition waivers for foster youth, and look forward to really increasing our efforts on that critical population in terms of transitioning into adulthood. In addition, there was a work group from Senate Bill 293 last session that took a look at what we should do in response to commercially sexually exploited children, and that's children who are subjected to human sex trafficking. We established last session the legal foundation on which to allow child welfare agencies to work with community partners to respond in a way that does not confine these children in juvenile justice settings, but rather views them as victims and increases their treatment. We had a great and incredible collaboration across the state on this topic, and so we anticipate that there will be a bill that really talks about what that service delivery system should look like, and are working to crosswalk what those services, which of those services might be already existing Medicaid billable, if there's other sources of funding to help that particular population. In terms of our division priorities, our upcoming division priorities, over the last year, we undertook a real strategic planning process that looked at what we do well through that prism of safe, healthy, and thriving. And we came up with 5 keys to transformation for our agency to really go into the future in an effective way. And so those 5 keys include robust community engagement, mature structure for 24-hour care, that's facilities or foster care, our commitment to our DCFS team member success and development, a strong exit path for families, which is one I'm really excited about, that says if we have a family come into the service of the Division of Child and Family Services, we want to take care of them when they're with us, but we also want to send them out into the world without us, always keeping our arms and our offices open if they want to come back and receive services, but to trying to prevent that re-entry in a non-voluntary way. And then similar to some of the data comments I've made, a program-centered use of data and technology. For us, this framework is really in terms of making sure we've got all this data, let's make it useful for the folks on the ground. And so as we considered the budget building process for this coming session, we did so through the lens of those 5 keys to transformation. Another key priority for us is the Family First Prevention Services Act, which passed a couple of years ago and is very different than the Family First COVID Act. So that's something I always have to keep in my mind. When they say Family First, I go to our act first without thinking about the COVID one. But it is going to allow federal funding to prevent and shorten the time children are in foster care. At first, when it first came out, it seemed like this was going to be a great windfall for states and we would get a bunch of federal money for these processes. That hasn't necessarily, as we've gotten more guidance from the feds, panned out. But there is an opportunity to access federal money for prevention services. I think in the prior presentation, we talked a little bit about the home visiting program. There's a possibility to be using some of these federal sources for that program. There are certain requirements on congregate care that come into place whether or not we access the prevention services. And so our position is if you're going to penalize us on the congregate care side, we're going to try to do what we can to access those prevention dollars. Slide 10 is a snapshot of our funding sources. For us, the federal funding, 4E, you'll hear 4E a lot. That is the Federal Social Security Act funding that supports the child welfare practices. And for us, other funds is a transfer from Medicaid. Our children's mental health and some of our other areas provide reimbursable services. And so that is the bulk of those other funds. The Victims of Crime funds is another large source of federal funding. On slide 11, you will see our caseloads shown by the year, followed by the month there on the bottom. So the projections start about halfway through. We have 3 different foster care caseloads. Family foster care is what I think most folks think about in terms of traditional family foster care or traditional foster care. We have a foster parent or foster parents taking care of children who are not their own, who've been subject to abuse and neglect, and work in concert with child welfare agencies towards either reunification with the parent or eventual adoption. Advanced foster care is a family foster care setting with additional outside supports for children with higher needs, particularly in the behavioral health arena. And then specialized foster care are agency operated houses where they provide the housing and the services, the behavioral health services on top of that. I will say that although we had that substantial collapse last year of Child Protection Services reports, there's no indication that that collapse has led to a collapse in the need for foster care. The next caseload we have is the adoption subsidy caseload. And what this caseload is that when we have a successful adoption out of a child welfare agency, the adoptive parents will work on a negotiated monthly subsidy for the adoptive parents from the child welfare agency. That subsidy cannot exceed the monthly foster care rate. And so that's what the adoption subsidy caseload is. It's that continued support after an adoption from when the child is adopted until the age of 18. So it has quite a big variable in terms of the cost per youth on that caseload. Slide 13 shows our average facility populations for fiscal year 2019 and fiscal year 2020. You can see our 3 juvenile justice facilities there on the top and our 4 children's mental health facilities there on the bottom. During the special session, the capacity at the juvenile justice facilities was reduced to 160. And you can see the fiscal year 2020 average population was 156. So that's about right. Slide 14 is our account summary. In some years, we have big differences because of grants between the fiscal years. We don't have that this session. We do have a request to create a new budget account, 4895, the Victims of Crime account, which would take our VOCA grant programs, our victim programs that were primarily in our administrative budget 3145, and the VOCA compensation program under one house so that we can really start to track in a clear way how much we are spending on victims of crime. As you can see, that budget account is completely a federally funded account. The enhancements in this requested budget, the first 2 are related to juvenile justice reform. The first one, we passed AB 472 in the 2017 session. It requires quality assurance reviews of the 3 state facilities and 2 county youth camps. And there's a cost associated with travel and training on that. That is that enhancement. In addition, as part of that big juvenile justice reform, the Youth Parole Bureau has to offer incentives for compliance for their parole conditions for youth. We've been using some grant funding, but this would that grant funding is not available going forward, and so there's a small general fund ask on that. A child welfare legal secretary, we've had a very long-term contracted position, and so this would just convert that contracted position to a state employee. And then a victim services manager, as we've really tried to tackle our role in victim services funding and coordination. It's been realized we need a social services manager to really oversee that entire program department in an effective way. In terms of reductions, the total general fund reductions for the Division of Child and Family Services for this biennium is approximately $16 million. The first reduction is office space, two office locations. The Kitsky Lane is administrative quality and oversight staff, and then the Pecos lease includes some direct service staff and administrative staff. We've been really, I guess, inspired by the success of the Division of Welfare and Supportive Services in outstationing their workers and taking the services to where the folks are. And so rather than have a family try to get transportation to our particular facility, the vision going forward is we'll do more and more stationing out in the community where our services can be more easily accessible. The next reduction is a reduction in incentive funding to Clark and Washoe counties. I talked about our unique structure before. There's a number of different funding sources that go from the state to the counties for child welfare operations. There's a block grant, which covers quite a bit. There's also a special program called the Incentive Funding Program. Each year, those two jurisdictions apply, and they have to explain to us how they want to innovate or improve practices. And then they're held accountable to benchmarks. And then if they've met their benchmarks for 1 year, they're funded for the next year. This reduction represents about a 50% reduction in that special incentive funding to those two agencies. The next reduction is a training contract with the increase of use of online training even before COVID. This was identified as a cost that could be reduced to find some savings in terms of more effective, less costly ways to train our workforce. The reductions on the next slide, the county youth camps. So we fund 2 camps. So we have the 3 state-run operated facilities, and then there are 2 kind of intermediate juvenile justice residential facilities, China Spring and Aurora Pines, which are co-located in Douglas County, and Spring Mountain Youth Camp in Clark County. And so as we took a look at the budget, this budget has really been inequitable in terms of the funding for a long time. And I wish we were in a position where we were increasing the investment in Clark County youth instead of reducing, in this case, the investment in the rest of the state. In this current biennium, the general fund contribution to China Spring and Aurora Pines is approximately $3,300 a month per youth, whereas the investment in the Clark County camp from the general fund was $480 a month per youth. So this decision unit would equalize the funding, giving each camp $500,000 in general fund a year. The next decision unit is really a continuation of the reductions we saw from the special session. So it holds 63 positions open at our 3 juvenile justice centers. It reduces our overall capacity. The state capacity remains at 160. So this is not an additional cut to capacity from the special session. It just continues that with those positions and capacity having the ability to be restored in the second year of the biennium. And then the last reduction, we have a source of the Title 4B1 money in terms of child welfare funds. In an ideal world, we would get all that money out into community service providers. We are permitted to use it for care coordination and case management services of our staff. And so that is what that decision unit is. When we take a look at the positions, when it's all said and done, the Division of Child and Family Services would have 2 less positions at the end of the biennium. Those are those transfers to the director's office for the Office of Analytics. So not actual elimination of positions serving Nevadans, but just they're going to not be within the Division of Child and Family Services anymore. We have one bill draft request. Last session, the legislature approved an enhancement that allowed us to have a criminal investigator to meet our compliance with the Prison Rape Elimination Act. We went through that process and then discovered that there's an NRS in the post chapter that says who can hire criminal investigators, and the Division of Child and Family Services is not one of those. And so this bill would just do that legislative fix or that NRS fix so that we could execute the hiring of that position with compliance with the law. And so with that, I am happy to take any questions at this time.
Thank you very much, Mr. Armstrong. I believe I'll go to the speaker first.
Thank you. Thank you, Madam Chair. I have several questions and indulge me a little bit. Mr.
for it.
Armstrong, thank you. Mr. Armstrong, you had indicated at the outset regarding DCFS and the various county departments that Nevada is unique in the jurisdiction between the state and locals. I don't believe you said it exactly that way, but can you elaborate on that and whether that is a good thing or a bad thing?
Absolutely, Ross Armstrong for the record. There are states that have where all child welfare is all state agency doing it all. And then there are some jurisdictions where it's completely county operated. I think there are 3 or 4 that have kind of a mix in terms of the state does some and local counties do others. In the state of Nevada, the way we used to have it divided a while ago was that counties were responsible for child protective services. So you get the call, you go investigate. If that child needed to come into care, into foster care, then that's where the state took over. And so that's how it was throughout the entire state. At this point, so the legislative change that said, let's have Washoe and Clark operate their entire agencies from start to finish. And then the rurals under the state agency. There is an option in the NRS for any rural county to take over their child protective services again, if they wanted to. So far, since the change, no rural county has elected to do so. There are benefits and costs and benefits to each structure type. One of the things that it does allow is that there can be some innovation and creativity and meeting those needs of those 3 communities, right? When you think about the rurals and Clark and Washoe, they're very different communities. And so a one size fits all approach, especially with this vulnerable population, I don't think would be overly helpful. There are some things we can do in terms of statewide oversight to make sure we're all rowing in the same direction. But the structure, I think it has worked out pretty well for us. There's some questions about who's on first in the eyes of the feds in terms of the Department of Health and Human Services at the federal level and the Children's Bureau. The Division of Child and Family Services remains responsible for statewide compliance with federal rules. So there is some continuity that overlays the entire state. But certainly, I think having agencies that know the communities they're working with and have the ability to be creative in their approach based on the different dynamics of their communities, I think overall is a positive for us.
Well, you noted the difference between Clark and Washoe and the rurals, but then simultaneously started talking about state oversight. I think I'm just a little concerned about whether state oversight would be appropriate considering the uniqueness of all the different counties and the community they serve. I agree creativity is great, but wouldn't state oversight kind of inhibit that?
I think the biggest question for us since we switched up the structure has been, what is the role of that oversight? And what the direction we're trying to head with our quality and oversight team in the Family Programs Office is that we have statewide policies that ensure we meet those federal guidelines, but to the extent we can have local flexibility, we want it. So for example, with the Family First Prevention Services Act, there was a separate bill passed afterwards, after Congress said, oh, we passed this bill and we didn't give you any support, but so they gave us some funds. And our approach is we have this bucket of funds. We'll see if there are some statewide activities where there are efficiencies in doing some projects statewide, whether that's with our information system or training, those types of things. But hey, those 3 entities that do your child welfare work, submit to us your scope of work and how you want to spend this funding to get us to that point of doing true prevention. So it's a balance. It's been a difficult one to figure out. I think some statutory clarity in terms of the oversight functions could be helpful down the road. And so that's kind of where we are in that delicate balance.
Thank you. You had also mentioned specialized foster care program and implementation. Obviously and you know, Mr. Armstrong, I've worked in child welfare for several years. I don't anymore, but I wasn't aware of. It seemed to me that the shift was going away from DCFS housing and more toward the local. So let me get the question is with respect to the, I think it's 1915I specialized foster care. What's the current status of the implementation of that?
Thank you for the question. So specialized foster care has been funded kind of in a different patchwork for a long time. And so the specialized foster care, the licensure, the oversight, that's all done by one of those three entities, right? Washoe, Clark, or the rural region. And so the question is, how do you effectively pay for high quality care in specialized foster care? Some of the regions were utilizing basic skills training and psychosocial rehab. The issue with having those populations served by basic Medicaid services is that if there are changes to those services statewide, then those children are impacted. And so we took a look at what would be the best way to ensure quality care for those youth. And so we worked with stakeholders for, I think, about a year in terms of creating this state plan that is specialized to this population. It's been submitted to the Centers for Medicaid and Medicare and approved. We're working on an amendment to make it a little easier for implementation on the ground level. But it essentially is a plan for those youth that are in specialized foster care that will have services tailored to their needs. There's also, as a requirement of creating the special plan, some quality oversight and assurance pieces that our children's mental health team will be completing. So it's been approved. We worked with Medicaid. They were able to get it figured out in the system to execute, and providers are going to be trained in the next couple of weeks. And so by the time the session is over, we should be well on our way to having that program implemented. The nice thing is that now that this is created, there's an opportunity to change it in the future as there are changes to the needs of that particular population.
Thank you. And I wasn't aware we were approved or that implementation was approved. Was that recent?
Yeah, that would be late last calendar year, I believe is when we got. I would have to double check with Ms. Bierman and the Medicaid team about when the final approval was. And now it's just getting the actual nuts and bolts of the implementation completed or underway.
Okay, thank you for that, Ms. Armstrong. I wanted to ask you a question on one particular slide 13. It looks like it reflects that the number of kids being served has gone down. And so I'm curious as to what community supports are in place to support these families that are not being served based on slide 13 anyway.
Thank you for the question. Is there, are you talking about the juvenile justice facilities or the mental health facilities or both, just so I have clarity on what you're looking for?
Well, I was writing notes as you were going, so I'm trying to minimize multitasking. I had a note that it was on slide 13.
Yeah, so I can talk a little bit about both. In juvenile justice, the vision of AB 472 from the 2017 legislative session is that we would start implementing evidence-based programs, that we would have a validated risk assessment tool that could help us understand the true risks and needs of each youth and family, and get them in the appropriate level of services. And so as we've implemented that, I think that we're finding some youth are better served by continued services in the community on probation rather than going to a state facility. And I think I'd like to make general statements about the girl population and our work specifically in treating victims of sex trafficking as victims and not criminals. But that population is really volatile in terms of where we are. So those go up and down. And so I think overall we've seen that reduction. I mean, there's a national movement to reduce the number of kids we are locking up. And so I think we are following that movement. What is not fully reflected, was not reflected at all in these numbers, is that there's been a tremendous effort to reduce populations, especially at detention centers, and the commitment of youth to the Division of Child and Family Services based on the risks of COVID-19 and transmission in congregate care. And so in terms of children's mental health, again, I think the same thing in terms of working with our mobile crisis units and children's clinical teams and our wraparound and Nevada teams to try to serve families in their homes rather than have their children go off and come live with us for a while. I would defer to Deputy Susie Miller if she has any other thoughts in terms of the declining population and how those families are served.
Susie Miller for the record, Deputy over Residential Services. The only thing that I would add again is the front end services, and then working on when youth do come to us, really working to engage the families and provide to them so that the length of stay is less and that they are more successful whenever they transition back home.
Okay, here we go. Okay, I'm not. Oh, okay. I appreciate that. I expect that we're going to have more conversations about this once we get into subcommittee, because I am very familiar with AB 67 from 2013 and treating victims of trafficking as victims, but I haven't yet seen what we're actually doing to treat them as victims, and I don't know that just not housing them is what we had in mind. I want to delve a little bit more into what actual services we're providing to these people, since they're, these young folks, since they're not being housed, and the population's going down. But I'll digress on that point for now, and move on to extended foster care. I believe there are proposals to do an opt-in on extended foster care and also keep AB 350. And I'm kind of, can somebody speak to the notion, the cost factor of that being passed on? And I want to put it in context. We're talking about where nearly 80% of the state's population is near, a large majority of where the challenges are. And I think abuse is up and domestic violence is up during COVID when folks are at home more. Folks are unemployed, and we're punting more burden onto the counties that are already carrying this burden. So I'm just kind of curious about what the thought process is with proposing to make a policy adjustment that passes additional costs on to jurisdictions that are already really carrying the weight of COVID in particular in this arena.
Thank you, Mr. Speaker. This is Ross Armstrong for the record. So the group that met together during the interim as a result of AB 150 presented, I guess, 3 options to the Interim Committee on Child Welfare and Juvenile Justice. And that committee determined that they didn't want to scrap the current continued jurisdiction program and just have the federal program. The differences between the two are very, very slight, and to provide that opt-in program. So I'll defer to Deputy Roos, who was part of that work group and led that for some of the more detailed answers in terms of the costs between the two programs.
Catherine Roos for the record, Deputy Administrator, DCFS. So as Administrator Armstrong mentioned, in 2019, AB 150 passed that required a study of ways to improve outcomes for youth aging out of foster care. And one of the main goals of that group was to look at our current process in place for youth aging out of foster care and consider the adoption of the federal 4E extended foster care program. The difference fiscally, the main difference fiscally is that our current program is 100% general funds, and the federal program allows for a federal match. So right off the bat there, we're saving on those monthly maintenance payments, which is $773 per month for each of these young adults who have aged out of foster care. In our fiscal calculations, there was still some work to be done to figure out what exactly the impact would be on the workforce in each of the jurisdictions in terms of the difference in requirements between our current program and the federal program to be able to draw those federal funds. We do have more work to do to really dial into what exactly the fiscal impact would be. Although the recommendation that came out of the interim committee was to not to scrap one, but really to allow both programs to run side by side to see if the savings were realized with the federal program that would support moving over, more or all the way eventually to the federal program.
Okay, thank you. And then, like I said, I believe we're going to have continued conversations once we get into the session in subcommittee. Just a couple of more areas. Could you address, or one of you address, and forgive me for not recalling what this stands for many reasons I should know, but there's some recommendations with respect to CSEC. And also, I just want to group it all in one: proposed cuts to block grants and incentive applications and child welfare training. Can you just speak to the rationale behind that? What the recommendations are in particular, what the rationale is behind that?
Catherine Roos for the record. I'll start with CSEC, which stands for Commercially Sexually Exploited Children. This was another 2019 interim study bill to examine ways to support commercially sexually exploited children, to get them, as Administrator Armstrong mentioned, to get them out of the juvenile justice system and to be able to serve them in a more therapeutic way. And so the bill really focused on housing and services. So the SB 293 group met through the interim, and we submitted our recommendations to the interim committee on child welfare and juvenile justice around ways that we may provide safe housing for this population, how we can train community providers, how we can train child welfare providers. And so essentially the recommendations of the committee were around short-term and long-term housing options and training and services. And then you may have to remind me what your next questions were. My apologies.
Block grants, incentive applications, and child welfare training.
So the child welfare training, sorry, Catherine Roos for the record. The child welfare training was a reduction. Our child welfare staff are trained by UNR and UNLV through the Nevada Partnership for Training. Due to COVID and a lot of our training moving online, some of those savings were realized just through the provision of online training, savings on travel, per diem, and those associated costs. It may also have an impact on some specialty trainings that we were planning to have, but it wouldn't impact any of our traditional child welfare workforce training. And if you don't have any questions on training, we'll move to the next topic.
Yes, the next, you mean of my questions? Because I have one more.
I think this is Ross Armstrong for the record. I think the one thing I wanted to clarify is that there's no proposed reduction to the block grant for child welfare agencies. It is only the incentive funding account.
Thank you. And like I said, we'll follow up and look to, have some additional conversations. about that. Madam Chair, my last question, I think for now, is related to the issue of pepper spray and the investigation at Summit View, and to what extent that is going to cost us money, and what the status is of addressing that practice.
Administrator Armstrong, for the record. We received notification from the Department of Justice that they were looking into the use of force, particularly the use of pepper spray at Summit View Youth Center and the Nevada Youth Training Center. We have not yet received the initial request for information. So the scope of exactly what they are looking at, we do not have. What we know in terms of these types of investigations, they're really looking at if there's a systematic violation of rights, and there's not a fiscal penalty type of cost. However, if they do determine that there are issues within our system, they may mandate certain policy or funding changes over time through a settlement process. But the process itself at this point is way too early for me to be able to speak to any potential costs or ramifications.
Okay, I can appreciate not knowing the cost, but are there steps being taken prior to any response from DOJ? Are there steps being taken independently to address that practice?
Administrator Armstrong, for the record, again, the use of force is a topic that the Juvenile Justice Oversight Commission has looked at thoroughly over the last year. We had a large meeting with lots of data presented last January and presented additional use of force data, including the frequency of OC spray at their December meeting. Its use is at this time rare in our facilities, and we have, I believe, sufficient and substantial oversight and review any time that those occur. And so I do not think there needs to be a change at this time in advance of the Department of Justice process going forward.
Okay. I mean, I'm sorry, Madam Chair, Mr. Armstrong. So are you saying that are you saying that this is an occasional bad actor and not something policy-wise that's allowed or encouraged? It would seem to me if it happened, there needs to be at least a plan to make sure it doesn't happen again, regardless of what DOJ does.
Yeah, I know that Deputy Miller has, I believe she has the numbers handy, but over the last year to 18 months, we've had a substantial decrease in use of the OC spray. And so I am comfortable with our current practice. There are, in all human services, there are errors made or bad actors, and those are, I believe, appropriately addressed. And I'm happy to provide any sort of data or policy language to any member of the committee that has additional questions.
Thank you, Mr. Armstrong. If you do have policy in particular about these pepper spray, I would appreciate it. And the other issues regarding services and to what extent they're actually being provided, I think we'll be able to delve into in the subcommittee moving forward. Thank you, Madam Chair.
You're very welcome, Speaker. Thank you for diving in on that. I believe I have Assemblywoman Titus next.
Thank you, Madam Chair. I appreciate the time. And Administrator Armstrong, thank you for your information and what you do for the children of the state of Nevada. I appreciate that. I have two separate budget items that I have questions on. The first one is on the victims of crime funds that you have. And you mentioned that that's all federally funded. Is that correct?
So Ross Armstrong, for the record. So the The account would include the federally funded programs. The vast majority of that is the Victims of Crime Assistance Program and the Victims of Crime Compensation Program. There is a program that utilizes marriage license fees, so not general fund, but marriage license fees to fund providers of domestic violence and in some counties, sexual assault. And so that, so it's that combination of the federal funding and the marriage license fees that fund those services.
Now, are you tying any of that, since the horrific event of October 1st, or as some folks call it, Route 91 event, those folks were all victims of a crime. Are any of those having access to some of their mental health concerns through that Victims of Crime Fund?
Administrator Armstrong, for the record, and I'm going to defer to Deputy Administrator Davis, since she's overseeing that. But I mean, I actually think out of the horrific tragedy that was the Route 91, there's some amazing changes that are going to happen for our communities, and that includes recognizing the behavioral health needs of victims. But I'll let Ms. Davis speak to that, as that she oversees that program.
Thank you. Mandy Davis, Deputy Administrator over Administrative Services for the division. We did receive approximately $16 million in federal funds to support the response and recovery efforts after the Route 91 shooting. We have paid out about half of that so far to both community providers who are providing the mental health services, counseling services, assisting them with applying for any other needs that they may have, whether it's TANF or Medicaid or our other Victims of Crime Compensation Program. We have served approximately, I think the last number I saw, there was upwards of 15,000 victims that we have served in one way or another. As you might be aware, the concert had an attendee list of approximately 22,000. Plus all the vendors and workers, bystanders that were involved in the incident. So the victim population here was quite significant. But yes, we have been working closely. We have several subrecipient providers located in Clark County that we have been issuing funds to provide those services to victims. California, because such a large proportion of the attendees were from California, they actually received their own federal grant to support this population. So they have also been providing the services to the victims who reside in that state.
Thank you for addressing that, because that was going to be my next question. Was, we know that so many of those victims were out of state. And I was just wondering, how was this money, and especially from a mental health aspect, how did these folks apply for this mental health assistance? And do you know if any other states were able to augment their mental health system via federal funds from victims of that terrible day?
Again, Mandy Davis for the record. California is the only other state that received federal funds as a result of this incident. The Anti-Terrorism and Emergency Assistance Program, or AEAP, is a specialty program that is only awarded to states or jurisdictions that have a mass casualty tragedy. So Florida received one for the Pulse nightclub. Boston received one for the Boston bombing. So it's a very specific grant that's only awarded to communities that have a mass casualty incident like this. As far as providing mental health services, the Vegas Strong Resiliency Center has been established in Las Vegas. That has shown to be very successful in terms of outreach, where victims can go to be directed to services that are most appropriate to meet their needs. Even through COVID, they had to close down their buildings, the physical location, but their online presence has really expanded to really reach out to not just the victims that are in Las Vegas, but throughout Nevada, throughout the country. We even had some attendees of the concert that were from out of the country. So they've been really successful in providing that outreach and that point of contact to coordinate that support that those victims need.
So thank you for that. Administrator Armstrong mentioned, Ms. Davis, that there was funding for that Route 91 mental health fund, I think through 2 years. Is that where you're basing that $8 million that you have left? Or how do we secure funding past that, because these mental health issues don't go away in anybody's, just because there's a calendar year, okay, it's 2 years now, forget that mental health funding. This is lifelong, sometimes counseling, and just wondering about the capacity to fund that past a strong stop date.
Again, Mandy Davis for the record. We received the total of $16 million is effective for any services or costs that occurred on the date of the event, so October 1st of 2017. And then currently the grant expires September 30th of this year, of September of 2021. There is an option for a 1-year no-cost extension to that we have applied for. We are waiting to hear back to see if that will be approved. So that would allow us to spend down those remaining funds through September 30th of 2022. We are in communications with the VSRC, the Vegas Strong Resiliency Center, some of the other providers to see if we have any other options to continue supporting these services. As you said, the needs of this population and victims in general just doesn't go away as soon as the money runs out. So we are in talks and seeing if we have some other options, whether it's state funding, private donations, any other federal fundings that we can apply for, or a combination of all three that can continue supporting the needs of this population.
Great, thank you. Because these mental health funding is at such a dire need throughout many, many different levels. And this one event was, such a huge event. I just want to make sure that we have already anticipated losing that funding. And so, Ms. Davis, you're off the hook now, because I wonder if I can speak back to Director Armstrong on the China Springs youth camp here in Douglas County, if I could get some more details on that and the decrease in that funding.
Yes, this is Administrator Armstrong. As I stated in the original presentation, I wish we were in a position where we were making the funding even by increasing the funds to Clark instead of reducing the funds to the China Spring Youth Camp. It's an important and critical piece of our whole juvenile justice service landscape. But in terms of taking a hard look at the inequity between the two programs, this is where we landed on in terms of meeting the reductions that were requested and needed based on our fiscal.
And we'll hear more about this particular budget item when we get down to the subcommittees and maybe speak to the folks China Springs, because it's my understanding that that's multiple counties, judges refers to a youth to the China Springs, that it's not just Douglas County, but there's multiple counties that send their youth there. The counties put in some money, the state puts in some money. And I'm just wondering if that drawdown wouldn't even possibly eliminate the very viability of that facility, and just wondered, and I'm sure that I'll be able to see more details when you submit them later on, but I have huge concerns, because what I'm seeing here, you gave $487 million to the Clark County facility, so you're going to increase that by 23,000 by giving them $500,000, but the China Springs one was 3.9 million and giving them only $500,000. I mean, that's a significant budget reduction. We heard in testimony last session, and you and I've had a conversation during those hearings about how low that was, and that they testified last time, their administrator was there testifying that was not sustainable, what the budget reductions were from the last biennium. And I'm just hugely concerned about the impact of taking away that amount of funds, and will they even remain viable? So we're going to have a discussion on that. Of course, we're going to want some county input, some of the juvenile justice courts input, because this doesn't just affect just one decision unit. So as you can come up with some more information, I'm sure this committee would like to hear that.
Yes, thank you. Ross Armstrong for the record. It is the China Springs funding is a lot more complex than the Spring Mountain one, in that you do have county contributions. This is a service that those counties rely on. And so we have some meetings set up with county representatives and then camp representatives also We did not, in this particular decision unit, decide to mandate increases to the county contribution to offset the general fund reduction. And so I anticipate we'll have lots of robust discussions on this particular decision unit. And I'm hopeful with putting our heads together, we can come up with a good path forward to maintain the camp, because they provide a tremendous service.
Indeed, they do, and I appreciate that, and looking forward to further conversation. And thank you, Madam Chair.
Okay, thank you, Dr. Titus. I believe I have Majority Leader Benitez Thompson next.
Oh, thank you. Madam Chair, I don't actually have any specific questions. I have lots, but I feel like in the interest of time, I'll ask them in subcommittee hearings.
Okay, thank you, Ms. Benitez Thompson. I believe Senator Brooks had a question. Senator, we cannot hear you. I can't hear you. I'm sorry. I'll go to Senator Dondero Loop for her question, and then we'll come back to you if that's okay, Senator. So Senator Dondero Loop. If we could go, Senator Dondero Loop, are you there? I know she was having technical difficulties with her connection earlier today. Senator Brooks, were you able to figure out your connection?
Can you hear me?
I can hear you now.
Oh, thank you. My microphone switched in my computer. This is about the reduction in funding to the camps. And I know Assemblywoman Titus brought up some of those issues and that raises. Mr. Armstrong, could you I missed it earlier when you said it. What does this mean to the per youth funding level now across those camps? This basically brings all three to the same level of funding. Isn't that correct?
It is. This is Russ Armstrong for the record. So it's closer to the same level of funding. On average, the Spring Mountain Youth Camp serves a higher population. So the per youth per month cost, given that they would be funded equally, would still be a little bit more for the China Spring Aurora Pines Camp. But it gets us much closer to equity between the two locations.
And thank you. And does the Spring Mountain get any Clark County funding?
Administrator Armstrong for the record. Yeah, so the way that the Spring Mountain Camp operates is they get that contribution, which is about $487,000 a year right now. The rest of the camp operations come from Clark County funds.
Thank you. Appreciate clarifying that for me.
Okay, thank you, Senator. Senator Dondero Loop, are you there?
I am.
And did you have a question?
No, I think Senator Brooks kind of went where I was going with Spring Mountain Camp. Thank you.
Okay, all right. Just want to make sure everybody had an opportunity. Are there any other questions from any other committee members at this time on these particular issues? I'm not hearing one or seeing anyone wishing to be recognized. So thank you very much, Mr. Armstrong and your team. Good conversation. We look forward to working with you during the session, and we'll see you once we get to Carson City. Thank you. And with that committee, that takes us to Aging and Disability Services. And I believe I have Ms. Schmidt as administrator available for the presentation on this item.
Thank you very much. Dina Schmidt for the record. Just give us one moment while we set up our screen.
Sure, no, that's fine. We move quick.
Yep.
We're burning daylight.
Okay. So Dina Schmidt for the record. I serve as the administrator for Aging and Disability Services Division. With me today is Ricky Robb, our deputy administrator, as well as Jessica Adams and Jeff Haig, our other deputy administrators, and Robin Hager, our ASO4. Beginning on slide 1 is our mission and vision statement. You should just click on that one. Okay, there we go. Sorry about that. And slide 2 is the organizational chart for Aging and Disability Services. Moving on to slide 3 is a summary of our operations. We have children's services, which includes our Nevada Early Intervention Program, as well as our autism treatment assistance programs. We also have developmental services, which are those services that provide supports and services to people with intellectual and developmental disabilities and their families. And then we also have the aging and physical disability side of the house, which are programs that include assistive technology, independent living programs, communication access programs for persons who are deaf or hard of hearing, as well as our senior and disability RX programs. And within our aging and physical disabilities is also our community-based care that provide in-home support services to seniors and persons with disabilities who are at risk of institutionalization. And then lastly, we have administration and quality assurance. Quality assurance is now become a part of all of our programs. I think last biennium, we talked a little bit about this, moving some positions into our administrative budget for oversight of all quality assurance activities. And so with that, we can move on to slide 4. I'd like to highlight a couple areas where we were able to be creative with our current resources and collaboration across programs that supported our communities over the last year during the pandemic. Our long-term care ombudsman program was unable to visit many of their sites due to the coronavirus pandemic. However, they were able to use federal dollars to purchase and deploy tablets and visitation stations to skilled nursing facilities throughout the state, allowing individuals to have access both to the ombudsman program, but also to their friends and family members so that they had the ability to stay connected. We also launched the Nevada CAN, which was the Coronavirus Aging Network Response. This was a partnership with Nevada 211. We created a coordinated online effort which provided individuals the ability to request immediate assistance with food, medication, telehealth services, as well as social supports during the pandemic. We've been able to sustain these efforts as well as expand our efforts through that program by using our Nevada Care Connection site. I'm happy to report we are now receiving referrals for behavioral health services through that site and sending those referrals over to our sister agency at Public and Behavioral Health. And we are serving all populations. Really, the goal was to meet the immediate need, but with this expansion, we now have the ability to meet an individual's immediate need for services, but also help them plan for long-term services. In addition to that, this last biennium, as you remember, we did expand elder protective services to adult protective services. And this implementation has been very successful. We opened more than 7,400 cases in fiscal year 20. Moving on to slide 5, our division priorities. In light of budget reductions that were needed during the biennium, we really tried to focus on a couple of key areas. One was just maintaining our services. As you know, all of our programs serve some of the most vulnerable populations. Many of those are the ones with the most adverse to negative effects related to COVID-19. And so we really just focused on trying to maintain and current services. And our second area of focus was infrastructure supports. Over the years, our division has grown by 28%. We've had 28% growth in our FTEs and 39% growth in our budget since fiscal year 16-17, but with no additional HR, IT, or fiscal support. Slide 6 is our budget by funding sources. And Moving on to slide 7, we begin to the review of our caseload and our projected caseloads growth. So on slides 7 through 10 is the caseload growth charts for our developmental services programs. And on page 11, you'll find a summary of all of those caseloads for each of the regional centers as well as our family preservation program. Showing that we are requesting an additional 19 positions to support caseload growth for these services. Slides 12 and 13 indicate our children's services caseload with a summary of those two programs on slide 14. We are requesting an addition of 5 new positions to serve caseload growth in children's services, 4 of those for the autism treatment assistance program, and 1 of those in the early intervention program. Slide 15 begins, and through 19 actually include all of our non-waiver home-based services, as well as our long-term care ombudsman program and our adult protective services programs. The summary of these caseloads can be found on page 20. So on page 20, you'll see that we are requesting the addition of 9 positions for the adult protective services programs, a reduction of 6 in our long-term care ombudsman program, and a net reduction of 2 positions in our community-based care programs. I would note that COVID has had an impact on many of these caseloads, and those are the reasons some of these are showing reductions. We do anticipate perhaps some adjustments in the next caseload projection, especially for our long-term care ombudsman program, who were prohibited during the pandemic from visiting sites and who are now slowly returning to those facilities. We are working closely with folks at Public and Behavioral Health to make sure that we're only going into facilities that do not have current outbreaks, but they are excited to be back in. So we anticipate a slight uptick in their caseload going forward. Slide 21 is our facility populations. Aging and Disability Services operates one 24-hour facility. This facility provides services and supports to individuals with intellectual and developmental disabilities. Our average census is 39. We do have the ability to serve up to 42, I believe, in that population, but we've been averaging about 39. Moving on to slide 22. This is our budget account summary for all of our budgets. Slide 23 is some of our major enhancements. While these are really, as Director Whitley mentioned earlier today, these are really no-cost enhancements. They're transfers of programs in alignment, really aimed at improving the consumer's experience. If you think about the complexity of our healthcare system and our social service systems, oftentimes individuals, especially during COVID and through our Nevada CAN project, we've identified that people call multiple agencies, multiple numbers, multiple community partners. And while they may get a single service that they needed, they're often not connected to the next step in services, so that longer term transition. And we've really identified that the thought is consolidating these programs that start at the lowest level from information and referral all the way up to our adult protective services programs. So individuals could need any level of help and advocacy trying to get through our systems. So having all of these programs under a single agency will really help us start to collect data in a consistent manner and help us be informed about what are the gaps in services, where are the gaps in services, which populations are being underserved, and really using that data to inform all of our programs and all of our policies going forward, including recommendations. I think we have close to over 10 different commissions and boards who represent specialized populations. So having the Consumer Protection Commission here, where each of those populations has a place to go and make recommendations to and share their experience and the data along with caseloads. So that's really the thought behind this, is really to figure out how do we make sure that people that are calling 211 For simple information, get simple information quickly. But those that need the next level of advocacy are able to be warm handed off to an individual who can help them get through that system. And then those that may need even more than that, somebody to come to their home and help them fill out the application, all the way up to somebody who may need adult protective services interventions. So that's really the goal of this transition and alignment of programs. Slide 24 provides a summary of the budget reductions. We are deferring replacement equipment and holding frozen 93 positions in fiscal year 22. We are proposing a monthly rate reduction to our community providers in our early intervention services program from $565 to $500. Also a rate reduction in our fiscal intermediary program from $450 to $300. And then we did put forward an elimination. We had an enhancement unit to provide specialized services to individuals with intellectual disabilities needing a higher level of support. And we did eliminate that enhancement unit as part of our reductions. Moving to slide 25 is a list of our position summaries. Again, keeping frozen those 93 positions in fiscal year 22. You'll see on here that does include the transfer of the 3 audit positions mentioned earlier by Administrator Bierman. Slide 26 is the agency VDR. This is in our Senior and Disability RX program, really trying to align the eligibility criteria in statute with some of the changes that have been made in the federal Medicare Part D program. And this will allow us to have a program that can better meet the needs of individuals in those services. So I know I moved rather quickly through there, and I will be happy to take any questions you may have.
Thank you very much. We appreciate that. I believe one of the questions earlier today, which was a full answer was put off until now, was on autism. I know during the special session, there was a lot of conversation about the autism budget and some of the cuts that were made there. It's my recollection that the reserves were very substantial and the funding that was there was able to get them where they needed to be. And that's why some of the adjustments in that budget was made. If you could elaborate, remind everyone about where we were then and where we are now and what direction you're going with the autism dollars.
Absolutely. Thank you for that question, Dina Schmidt, for the record. So you are correct. One of the areas that we've seen in the autism budget is that the cost per eligible, while we are serving everybody that's currently in the program, the cost per eligible has gone down, partly related to COVID. And so we are able to reduce the total spend in the autism program, but still the budget we are proposing and the governor's recommends includes the ability to serve all children currently being served, as well as all children on the wait list. So there will be no cut in service. It looks like a budget reduction, but there will be no cut in service.
And I might need to let the majority leader hop in here, but we just in audit subcommittee had the review of the autism funding. So I think there's other issues there that we're probably going to need to dig deeper into so that we can have a comprehensive discussion about how the funding's working, how the services are being provided, and what truly is a wait list and what the expectations of getting those children off the wait list. Okay. Majority Leader, did you have any comment?
Oh, thank you, Madam Chairwoman. I don't right now. I think it's probably going to be some through course of conversation just to figure out where we land. I do see here that there's a request for new staff folks in the ATAP program, and I know that through the course of the audit, you folks were requesting additional new positions, but not in this biennium, in the next biennium. So I know that we had talked about that, so I'm not sure or that's reflected here on page 14, if we might be closer to actually 8 as what would sincerely be needed to kind of get us where we need to be. But I think we can start working that all through and make sure we've got services really hitting the ground in a great way.
Okay, thank you, Majority Leader. I believe I have Senator Kepler next.
Thank you, Madam Chair. Appreciate it. I had a couple of questions. The first was on the Consumer Health Advocacy and Protection Unit and the various sort of components that are being transferred in, whether it's Office of Consumer Health Assistance, 211, Adult Protective Services, Community Advocacy Program. Those seem to be really sort of individual consumer focused. But the Patient Protection Commission seems to me as sort of the odd duck in that group. It's focused more on policy, on issues that are somewhat outside of your division as well. What's the thought process on bringing that into your division?
Tina Schmidt for the record. So I think I see where your concern is with their focus, but I think one of the areas is the populations we serve and bringing all of those programs in. One of the goals is working internally as well as with the Office of Analytics in collecting data related to all healthcare. Many of our folks, while we may provide a service, they also access Medicaid. And so really being able to collaborate across the department and gathering the data to feed the information to the Patient Protection Commission and working closely with them across the department to make sure that policies are being addressed that need to be addressed to serve the most vulnerable and to improve healthcare across the department, or across the state, I should say.
Appreciate the response. And then, probably no big surprise, Nevada Early Intervention Services, I'm looking at both the staffing changes and the reduction in capitated payments to external providers, community providers. Starting with, it looks like you're making about a 25% reduction in NEIS staff in the first year that's being carried into the second. Is that a cost-saving measure or right-sizing?
Dina Schmidt for the record, it's a little bit of both. Cost savings measure, absolutely, for the rate reduction is a cost savings measure. The staffing, one of the things that we took the time to do is evaluate our staffing components this biennium. We were recognizing what staff were related to caseload and which staff were related to administrative duties. So some of those changes are strictly a result of that work. We kind of had when we did that work and that analysis, we realized we were out of balance when it comes to actual direct care staff versus supervisory staff versus administrative. And so part of that is just aligning to that methodology that really didn't exist prior to this session. So we really did a lot of work. If you recall last session, we were able to receive the management analyst positions for that budget. And that is the work that they have done over the last biennium. They've been working diligently to dig into that caseload and have a better understanding. And so that was part of the result of that.
So trying to maintain the 50-50 split between community providers and in-house providers, have you evaluated what a potential rate reduction might do to that split and whether you'll lose community providers that would shift children back into state service or state provided services and then offset that balance that you're trying to create right now?
Tina Schmidt for the record. Senator Kiefer, I appreciate that question. In fact, that is something that we have been working closely with our community providers and would like to work with the legislators during this session is to really look at, does that 50-50 split make sense anymore? One of the things that we've noticed, again, with the use of our data analytics or our management analyst team is in this biennium, what happens is because we have the budget split between the two groups, the community providers caseload was growing and we actually had to stop it because of budget implications. And then, which doesn't make sense because families should be able to go where they want to go. And so I really think that we need to look at the opportunity to allow that caseload growth and shifting of funds during the interim to meet the needs of the families. Really, the money should go where the families go, rather than saying that it has to be split between the state and communities. We should be allowing, and the community partners are very receptive to this idea, is letting the caseload grow naturally and moving the funds accordingly. It really shouldn't be up to us to dictate that half of them have to go to us and half of them have to go to the community partners. And that would be an ability to, if their caseload continues to grow like we were seeing prior to having to cap it, that would be an ability, that would also offset this rate reduction if they were able to grow their caseloads.
I appreciate that. I certainly tend to agree. So thank you for your responses. Look forward to subcommittee.
And thank you, Senator. And I think we were both in the same room when this 50-50 split was first discussed. So I believe it's going to take a lot of conversation going forward on that, because a lot of families felt that if it went one way or the other, that they wouldn't get services. So it's a complicated issue. To follow up on you very briefly on the Patient Protection Commission, it's something that I worked on last session along with the governor, and I guess I'm trying to get a little bit better handle on why it's being moved, because it does not seem to actually fit the description that I believe I just heard from Ms. Schmidt. It's not about Medicaid patients. It's not about aged, blind, and disabled. It's about any consumer that has an issue with healthcare. And I'm just afraid, I just want to understand exactly what we're trying to do, because the goal was to be able to give the patients a place to go to hear their concerns, no matter what population that they were from. So I just want to understand the thought process again on this.
Dina Schmidt for the record. So I think if you look at the Office of the transfer of the Office of Consumer Health Assistance, those ombudsmen really work to advocate and help people navigate, exactly like you say, the consumer, help the consumer through the healthcare system, whether it be a billing issue, a prior authorization issue, access to specialty care. They really are the frontline navigators and advocates on behalf of consumers of healthcare. So aligning those efforts and having the data about the types of concerns and questions and cases that they're seeing gives us the ability to work closely with the Patient Protection Commission and feed them actual data with the types of cases that we're seeing through the Office of Consumer Health Assistance.
And I understand that and appreciate it greatly, but the Patient Protection Commission actually takes it to a higher level, where they actually analyze what's going on in the state to make sure that industry and everyone is acting accordingly so that patients are protected. It's not necessarily about advocacy. It's about analytics and looking at the state of healthcare in our state and how it impacts the people of our state. So it's not necessarily a complaint-driven process. This is more of a top to bottom process on policy and where the state is. So I think we'll just need to have more conversations about where we're going. I do like the idea of data. We definitely need that. We've tried to make numerous changes in this state when it comes to healthcare. And because we don't measure and monitor it, we don't have the data to hold up in order to substantiate some of these changes. And that was another thing that the Patient Protection Commission was going to look at, so that as we looked at policy changes, we would have data. So I look forward to working with you and your team and discussing how this all blends together, and just make sure that that function also gets done. The consumers have a place to go. This was about a much bigger plan. So we can have that conversation a little bit more as we get into session. I believe I had Dr. Titus next.
Thank you, Madam Chair. I appreciate that. If we might circle back to the long-term care ombudsman, I'd like to have I have a question regarding that. You mentioned in your presentation that a couple things, that you have 643 individuals there from the 2021 and moving it up to 860 individuals. Could you give me a breakdown on if you have a waiting list for that? When someone calls in, do you just do Medicaid patients? I understand that that's open to any family that has concerns about their loved one in a long-term care unit. And I'm just wondering what that breakdown is, if you're actually able to serve, because I don't know what the long-term care population is in our state, and that'd be another number I'd like to see at some point, maybe when we break down this in a committee.
Absolutely. Dina Schmidt for the record, thank you for the question. So the long-term care ombudsman advocate on behalf of residents. And so the couple different ways that we get a referral is, we do regular visits to all the facilities throughout the state. Oftentimes, just by walking through and talking to folks, we end up having to opening a case for them. We get calls from family members, we get calls from the facility, People can email in their concerns. We also coordinate some concerns with healthcare quality and compliance investigators who identify maybe a resident isn't happy. There's not necessarily a finding from a regulatory perspective, but a resident needs some help getting their needs met.
Are you able to respond to everyone that calls in? It seems like a very small number of cases that you have, 643. So that is it your duty then that any person, family, whether they're Medicaid, private pay, insurance providers covering their in the long-term care, you do respond to every single call. There's no wait list, and you can actually address anyone's concern if they call in for a loved one in long-term care?
Correct. That is Dina Schmidt for the record. That is correct. We do not, their insurance coverage is not an indicator of whether we would serve them or not, and there is no wait list. We address all calls that we receive and touch base with those individuals to see if we can advocate on their behalf and help them resolve their concerns.
Excellent. And then can you clarify for me the, you mentioned laptops that because you weren't able to get into facilities. Our facility didn't get any laptops. That was a whole big thing with the COVID shutdown, is lack of communication with families. And I think that's a huge issue because it definitely related to COVID, and wondered if there was, because not every facility got these laptops for communications. And I'm wondering, did you apply for any extra COVID funds for that particular program, or how was that funded?
Dina Schmidt for the record. So we used CARES relief funds for that. The Ombudsman program had an allotment of CARES relief funds. And so those were designated to those tablet purchases, as well as the visitation stations.
And how many did you say you were able to get?
Hold on one second.
Did you exhaust?
So Dina Schmidt for the record, I'm looking, someone's handed me a note. 650 were purchased, and they were delivered to all skilled nursing facilities and residential facilities for groups. So not necessarily acute hospitals or hospital settings. They were focused on the skilled nursing and residential facilities for groups.
Okay, very good. All right, very good. Thank you. Thank you, Madam Chair, for the question.
You're welcome, Dr. Titus. Any other questions from other committee members at this time?
Madam Chair, I had one, and it's just more of a request.
Yes, go ahead, please.
And it's that when we get into the hearings, I'm really very interested to hear more about the adult protection program, how that's been going. I know that we were asked to implement it during the interim. Memory doesn't serve me well if it was this immediate past interim or the last interim, but we were standing it up like in the middle of session. And so I think we have a fully baked program now that you folks have been operating for a year-ish or so. So I'm just excited to hear about it, hear how it's going. I know nothing about it. So when it comes to that piece, if that could be a little bit more detailed, since it's a new thing that you folks are doing. I'm excited to hear how it's working out.
Absolutely, we'll be happy to.
Madam Chair, I have a question, please.
Yes, Senator, go ahead.
So I'd like to go back to the autism information that was presented. And I see here on this ATAP that you're not really cutting specialists, you're reassigning so that you have 4 positions. And I understand that you said that the cost has gone down, but there won't be a cut in service. But I'm just wondering, and I'm just trying to pull this all together in my mind, because this says ATAP caseload has 933 children in fiscal year 2021. I know from a couple calls that I've had that there's like, I don't know, something like 4,000 kids on the list just at the Ackerman Center alone. And that I think it's like 60% of those kids are on Medicaid. So am I wrong about that? And will we be able to service them? That won't be a cut?
Dina Schmidt for the record. So I think the clarification is that when a child is diagnosed with autism and is enrolled in Medicaid, managed care, which is probably, I would have to know the numbers for Ackerman, but managed care, they are the provider of service in the care coordinator program, not our autism treatment assistance program. I think if you recall, some of you might recall last session, we had a lot of discussion about how we transitioned Medicaid managed care children from our autism treatment assistance program back over to the managed care program. So in our budget, we're talking about kids who are not in managed care. Those children that are in managed care are being served through the Medicaid program and through their managed care. I don't have that. I think some of that data was included in the recent audit about the number of kids receiving services through that program. So our intent is to continue to serve the children that are not managed care, and our budget includes a request to serve all of those children.
Okay, thank you. I'll just, go ahead.
I'd like to have Ricky Robb, my deputy administrator, just add a little bit to it. She has some more details about services at Ackerman, so that might be helpful.
Good afternoon, Ricky Robb, deputy administrator. I'd just like to add, in regards to Ackerman, that program is actually the diagnosing agency. And so that's not actually approving for ABA services, which is what the Autism Treatment Assistance Program supports families to receive ABA, Applied Behavioral Analysis Therapy. And the Ackerman Center is actually a diagnosing center for individuals who are suspected of autism.
Okay, thank you. That helps clarify it a little bit. I'm sure I'll have more questions as we get into this, but thank you for everything.
Okay. I believe I had a question from Assemblywoman Tolles, but I believe she messaged me that Senator Kickheffer had stole her thunder again. So we'll let that. Yeah, I got a chuckle out of you guys. Good, you're getting kind of serious. Are there any other questions from any other committee members at this time? These are very complicated budgets, and like I said, we're trying to keep a high level, and I really don't want to scare the new members too much if we dig in too deep, because they'll not want to come back to the committee hearings. So are there any other questions of any of the members right now on these particular items? I'm not seeing anyone. Thank you, Ms. Schmidt, very much for you and your team for being here today. We look forward to working with you once the subcommittee gets geared up. So hopefully we'll be seeing you in Carson City, probably virtually, in February. So thank you very much. And you now have an indication of what the committee is going to be looking for when we get into those hearings. So thank you very much.
Thank you.
So committee, that brings us to item number 9 on our agenda, which is our second round of public comment. We'll go ahead and give it a couple of moments. It's 2:34 by my clock. We'll go to 2:36. And if anyone calls in, and then we will go from there. Okay, we have 236 broadcast services. Do we have anyone in the queue for public comment this afternoon?
Thank you so much, Madam Chair. The public line is open and working. However, there are no callers at this time.
Thank you very much. I appreciate that. We've given them time to call in. So committee members, thank you all very much for your time and attention. It was a long day. We covered a lot. I'm very grateful to you all. We will move on from there. Tomorrow, the meeting will be chaired by Senator Brooks. So everybody come ready to get the work done. And with that, thank you all. We're adjourned.